both adult, postlingual and prelingual hearing to this world. And it is the main philosophy is the restoration of hearing, particularly bypassing the disease part and connecting with the functional part, particularly in the moderate, severe and profound loss, which may not be good give result by your hearing aid. Now, I think, I have not got your CV, but I mentioned your name and all that. But yesterday he has done a very good cochlear implant. On car we have enjoyed your surgery from Guwahati to Shivsagar. Let's start it.
भैया इसको स्लाइड के मोड में करो
स्लाइड मोड में सर एंटर आप टेकेंगे ना क्लिक पे एंटर
देन अपने आप आएगा
फर्स्ट वन एंटर मारेंगे सेकंड वन यहाँ में नेक्स्ट स्लाइड
ओके नेक्स्ट स्लाइड कैसे करना
It is not started. I think in Indian scenario, cochlear implant first by Sanda D'Souza actually. In South, Dr. Padul Hazarika was the first. He is here, I think, in Shivsagar. He is the son of Sahil Abni Shivsagar. And after that, many centers have come up. And as the presentation started, I request you to start.
Respected chairpersons and respected audience, all the delegates, I thank you very much from the bottom of my heart for inviting me for discussing on the topic of cochlear implant. It's my honor to be here amongst you, and I'll be discussing on this topic for half an hour. I'm Dr. Bharat Deshmukh from Dr. Hedgewar Hospital, Aurangabad, and now the name of the city changed to Chhatrapati Sambhajinagar. We run and trust hospital at Aurangabad, Maharashtra since last 35 years. I'm full-time working ENT surgeon there. Now we have established a Sukafa hospital at Shivsagar, and we are running since last 5 years. I'm happy to be amongst you. I'll be talking and dealing with the overview about the awareness, hardware requirement, candidacy, and surgery, along with the counseling required and post-operative problems in the cochlear implant cases. What is most important is this is all about happiness which ENT surgeon wants to get, or any person wants to get in his life. Cochlear implant is popular because it is a very costly affair and it involves a lot of money. But as far as the ENT surgeon is concerned, if you want to do a cochlear implant, there is more than money involved in that. Money of course comes with every work, but what is more than money is a happiness. So it's not about prestige, thrill or remuneration and fame involved in that, but more than that, it is happiness once the life gets transferred from deaf mutism to the other personality. So let us go a little quickly about the scenario of disease load. The load of disease, as we know, in congenital deaf mutism cases is, with every 1,000 live births, India gives birth to around 2 to 3 children who are born deaf mute. India gives birth to around 80,000 to 1 lakh children who are born deaf. All, if you consider the middle-aged deafness, presbycusis, and deafness in adults and deafness because of any other causes, the load is 291 per 1 lakh population. So that is the recent statistics which we have. Starting the CI program is talked a lot because it is about the transformation of life. It deals with the special sense. The cost involved is high, and every member of that team, and the team involved is team of many specialists, and each member of the team requires an training in that. It is giving a deaf population to the society rather than it is giving a hearing population to the society, communicating population to the society. It is said that deaf mutism is a disability only if it is not intervened early in life. The early intervention and awareness, these are most important thing. The still general population is not aware about the solution of deaf hearing. Likewise, the pediatricians, gynecologists, all the general practitioners, they required to be made aware about. We have to conduct, anybody who wants to work in the cochlear implant program has to conduct many awareness activities. You have to make aware by participating into the activities like any mela, jatra, or you have to conduct special camps for awareness. We have to conduct camps amongst the pediatricians and gynecologists. Just to give you idea, in our hospital at Aurangabad, we are doing auto-acoustic emissions, OAE, of all the babies who are born in our hospital since last 7-8 years, and we have done more than 10,000 babies. And it has been made as a protocol, and we try to do OAE and if required BERA in all the NICUs and all the nursing homes, and we spread this awareness amongst them. This is the first step. The second step is to conduct specialty camps, like camp for this in the village areas, and we go to the ASHA workers, we go to the Anganwadi workers and spread this awareness. So that is what is very, very important. The journey of the cochlear implant is not so easy. So this is the journey of the hurdles. There are many problems and speed breakers once you start the journey. And you have to go through the battery of the test. The battery of the test, it has to be stepwise. So after detecting the camp, after making the awareness, what is most important done is clinically examine the patient, then do OAE, BERA, then proceed for the CT scan, MRI, do counseling, and we have made a protocol for that. You have to do vaccination of all children who are being subjected for cochlear implant. The vaccination for the Haemophilus influenzae and for pneumococci has to be given to avoid the post-operative complication. We have to do a counseling of all these patient flow slide. What is most important is counseling. The fund requirement for cochlear implant is very huge, and you have to address the fund requirement. Everywhere government schemes are there, but some of the states do not have government schemes. And if there are no government scheme, we have to appeal to the donors, to different companies, CSR activities, and make that available. So we have made a patient flow so that we can go and we can record the time and date and what is their vaccination schedule and what they have done for the money arrangement, whether CT scan has been done, whether MRI has been done. Most important thing about awareness program that we have to understand and make the other faculties also to understand that hearing is a brain function. It is something which we have to do with the brain. It's not only the ear which is important, it's about the development which happens into the brain. So there is something called as a neuroplasticity. These neurons at birth are very few. And when child becomes 9 months old, the neurons, they they grow in the size and grow in numbers. These are the neurons which are there into the cochlea, we call as spiral ganglions, and these are the neurons at the auditory cortex also. There is fixed number of the neuron in the cochlea. How many numbers of the inner outer hair cells and inner hair cells are? So the number of the hair cells in the cochlea is only 16,000 to 17,000. There are only 12,000 outer hair cells and there are 5 to 6,000 inner cells. And number of the spiral ganglions is also fixed. What we have to do, this only the number of the neurons or synapses only increase after sound stimulus is there. And once the sound stimulus reaches the brain goes for the hard wiring. Hard wiring is, sound is not only a simple sound. Sound is not only the language. Sound comes with the intellectuality. Sound comes with the emotions. Sound comes with the particular knowledge of the particular object, particular process. And all that is to be understood as a whole by the brain, not only by the ear. And the maximum neuroplasticity, we call it as a neuroplasticity. Neuroplasticity is available at the age of the 2 years. So we have to do implant below 2 years of age. So anything which is beyond the 5 years, the chances of improvement even after implant goes on decreasing. So this picture illustrates that the organ of corti, outer cells, inner cells, and we have to pour the water to the plant when the plant is small. If the plant grows without any water, it becomes dried. Thus, likewise, in simple word, we will call it as this is a disuse atrophy of the auditory brain. So just I explain you the taste, touch, hearing, smell, sight. These all are important, and child or any person will remember all these things once he coordinates all these things with the words. So we have to understood again that the hearing and listening, these are the two different things. Hearing is a mechanical thing which comes to till our cochlea, and listening is when child pays attention, the processes that and understands and remember that word. So if once he listens to the sound water, so child gets an image of water, child gets a sound of water, child knows about the touch of the water, child knows water is a liquid thing, shape of the water. So it's not only about listening a simple word water, it's all emotions related to the water, its color, its shape and everything. So what is most important rule nowadays is brain has a capacity to grow very fast and to imbibe or to absorb all the sounds which are surrounding it. And this capacity is there in its fullest strength till certain age of life, and that age is till 1 to 2 years. And before that we have to intervene. If any unfortunate child is born with the hearing deficit, it has to be detected at the age of the 1, before the age of the 1 month. Till the 3rd month, the diagnosis should be confidently settled. That is, till the 1st month is over, child should undergo the otoacoustic emission. At the age of the 3 month, we confirm it by doing a brainstem evoke response audiometry, BERA. And at the age of the 6 months, we should give a hearing aid to the child and prepare the child for cochlear implantation. This is the formula decided and suggested by Joint Committee on Infant Hearing and is being followed in Europe and Western world. Now, who are the candidates? The candidates who are having a profound hearing loss by both the ears, and the candidates who are not responding or not showing any progress, even after giving an hearing aid, both-sided hearing aid, these are the candidates. But before that, Bera tells us that child is profoundly deaf and we have to do cochlear implantation and you have to do intervention. All the candidates who are having some minor comorbidities like a mild mental retardation, child which is having a little bit of delayed milestone and other Down syndrome or some other problems, and associated with that there is a hearing, they are not the contraindications. If God has given two disabilities to such a child, at least one of the disability can be corrected. Okay, if somebody is having mild mental retardation, we can't do anything for that, but at least we can make the child hearing child. So there should be adequate cognitive function. Cognitive function is a relatively difficult term to understand, but somebody is able to take care of the device and be able to use the cochlear implant, he should be given a chance for hearing. So, and all the parents who are having realistic expectation, they are the parents in whom the child should be counseled for doing a cochlear implant. If the expectations are unrealistic, there are patients sometimes who expect that child should be listening very, very normally. Child should be able to listen within a 1 month of doing implants. So we have to do counseling, prepare their mind, and then, because what is most important here, if the patient's expectations are different and you cannot do, or technology cannot provide that, then it becomes very difficult. The cochlear implant can be done in other cases, in adults also, because of the certain profound sensorineural loss, because the diseases like meningitis, like trauma, like there are some people who are having the problems because of the viral infection. Many patients present to us nowadays with the sudden sensorineural hearing loss. Now all these patients who are having, suppose somebody gets a sudden sensorineural hearing loss on both sides, and he is a professional, he is a young adult of 29, 30 years, what he will do if suddenly he goes without any hearing? So we have to consider a cochlear implant, because hearing aid is not going to be helpful. We try initially the hearing aid, but many times hearing aid are not helpful. The current indications as far as FDA is concerned, in children and adult, the child showing the audiogram like this, where there is a profound hearing loss, and adults also who is showing a profound hearing loss, both are candidates. See, this is the rule of 60. If an adult has already used, adult or children who has used an hearing aid, a strong and good quality hearing aid, and still is not able to communicate, a child or adult who is having more than 60 decibel sensorineural hearing loss, and an adult where the speech discrimination score is less than 60, he cannot reproduce the 60% words, then he is a candidate for cochlear implantation. Initially, as all of us know, that the cochlear implant started in a house clinic by William House. He was the person who clinically did the first implant in 1960s, and it was a very primitive single channel, single electrode implant, and then it progressed. He did a first implant in adult. Now the multi-channel cochlear implant came. So it was done on 1 year only. Then we thought, or the science thought, that we will be able to do implant in children. Then the scope of the cochlear implantation increased to such an extent that now the moderate deafness, which is around 55 or 60 decibel, and if somebody is not getting benefited by a simple hearing aid, he is considered for the cochlear implantation. I have already discussed with you that in presbycusis, otosclerosis, chronic otitis media, there are many patients of chronic otitis media who have bilateral cholesteatoma. In a due course of time, they face into a deafness, and they are in want of a cochlear implant. Now, for cochlear implant, the first investigation we advise is a CT scan, high resolution CT of temporal bone. This is a cut which is showing a well pneumatized mastoid and 3 semicircular canals. The side by there is also a coronal cut which is showing the 2 cuts out of 3. We also advise MRI. The most important thing in MRI, can I have a pointer? So I'll show with the help of this cursor, I think. There is, this is the cursor I got. In MRI, now look at this, is a sagittal oblique cut taken in a special oblique way, in which there are 4 black dots, and these black dots are also explained in this region. There is this is a facial nerve, this is a cochlear nerve, this is a superior vestibular, this is the inferior vestibular. The same thing is seen here, and cochlear nerve is biggest out of that. The cochlear nerve, if it is smaller than the facial nerve, then you should have in mind that probably the cochlear nerve is hypoplastic. But hypoplasia of the cochlear nerve is not an contraindication for the implant. If a cochlear nerve is completely absent, then it is a contraindication. A child is not going to be benefited. We want to study few important things, like this is a normal CT scan. This is an CT scan which shows an fluid or coalescent mastoiditis, and this is a bone where there is a dense sclerosis, and definitely you should expect some difficulties in finding, or major difficulty is finding the antrum and going further. This is another variation where you see that there is an normal CT scan which shows all the 3 semicircular canals. This is a jugular bulb, and which is very laterally there is almost as soon as you will entry from the post-oral incision, you will come across the jugular bulb. This is an cut which shows that just below the bone, outer table, there is a big vessel here, and you are likely to encounter the emissary vein there. So that's why it is important to have HRCT temporal bone done. Now here you see a high jugular bulb in this case, and in this case this jugular bulb is dehiscent at all. So this is likely to get ruptured, and you have to be careful when you do a post-tympanotomy. Now there are some congenital anomalies. These are not contraindications. The commonest congenital anomaly is type 2. This is popularly called as Mondini's deformity, whereby the third and second turn out of these 3 turns is fused to form an cystic shape, and this is most commonly seen. Type 1 and type 3 are little problematic in the sense that they are likely to turn, or the surgical challenge here is for the surgeon is because it will be associated with the gusher. So the gusher is a problem associated with these type of anomalies where IP1 and IP3, whereby there are no semicircular, there are no 3 turns, or basal turn is not seen. The modulus is also absent, and the gusher problem is expected because it is communicating with the internal auditory meatus. This is an internal auditory meatus, and it is directly in communication with the cochlea. So you are going to face a difficulty of a gusher in all these two cases, IP1 and IP3. I have already told you about the hypoplastic cochlear nerve. You go, it's the congenital anomaly doesn't mean that you cannot do implant. You can do implant, but with the less expectation. Child will not do as good as otherwise it will do. The cochlear nerve stenosis or stenosis of the internal auditory canal indicates the absence of the cochlear nerve. The central nervous system may have torch infection, some multiple sclerosis or infarct, and these childs are really contraindicated or may not do well with the cochlear implantation. Counseling is very important because I told you there are many problems associated with the parents, as the money involved in the surgery is very high. The patients have always in the mind that the child will grow and then will start speaking automatically. And there are many other misbeliefs that the child's father also was a late speaker, and he also developed speech little lately. So these problems are there. Again, there are problems related to the constant money which is required for maintenance of the equipment. So this auditory verbal therapy is must in all cases of the cochlear implantation. If somebody doesn't receive an auditory verbal therapy after implant is useless. So you have to do a good counseling that unless auditory verbal therapy facility is there, or child has some trainer or a speech trainer, without that the implant is not possible. There is a good family support required in all cases of cochlear implant. We do team counseling. All the team members, we sit together and discuss all these factors with the parents, and pediatricians, the ENT surgeon, the social worker, and all family members are given training. Counseling also is done extensively one day before surgery. There were 5-7 patients on one day, and all were counseled especially with this session. We have a written consent, and medical legally also it is important, and everything is explained in that. A little bit about how many companies are there. Cochlear implant now is available as a multi-channel implant, and all the 3 companies available, that is Advanced Bionics, Medal and Cochlear. All these companies are good, and their track record of last 30 years is similar. So we want to do disclosure that we are not being funded or by any company, or there is no contribution which comes to us from any of the company. The difference between all these are the compatibility with the MRI, 3 Tesla and 1.5 Tesla. Some of the electrodes are perimodular, near the modular, some are mid-scalar, some are peripherally placed. Length of the electrode varies with the company, and half or full band-aid is also a variation which is seen by some of the companies. So cochlear implantation is nothing but the competition with the many hurdles, and all cannot come across through these problems. Some of the patients feel we'll go to the surgical thing. The incision is like a routine post-oral incision, little posteriorly, 5 to 7 millimeters, and there is a little S-shaped extension which is given. So you to have a good pocket for the receiver stimulator. So incision is like any other surgery. Then we take a periosteal flap. This periosteal flap should be robust and Many different types of flaps are there. What routinely we take at our center is an superiorly based periosteal flap, and we try to use a minimum try to have a minimum bleeding, but it's not sometimes achieved. Sometimes we have a heavy bleeding because of the emissary. As long as we are not putting the implant in the patient's body, unipolar can be used, but once the implant is in place, we have to shift to the bipolar. The same thing has been told here. So next step is to do cortical mustardectomy. Cortical mustardectomy, now this is the zygomatic line, and we mark that zygomatic line, then we mark the line which is just posterior to the external aortic canal, and we go deep and so we do routine cortical mustardectomy to the extent that we should see a short process of the incus which is there near the suction cannula, and now we try to explain or explore. So in this we avoid to do a saucerization as we routinely do for mustardectomy, and as much as thin posterior canal wall possible that we go for. We then proceed for the posterior tympanotomy. Posterior tympanotomy is done between the facial nerve and the chorda tympani. So we have to do a sufficiently large posterior tympanotomy because our instruments, burr and forceps which is holding the implant array should go. This is the upper lip of the round window which is being drilled, which will expose the round window widely. And there are two approaches. We can place the implant through this round window, or we can do and separate cochleostomy. We are here in this video, we are doing a well for the implantation, whereby we want to put the body of the implant. Now this is the insertion which is going. This is the last step where the cochlear, the electrode has to be inserted very, very slowly and avoid trauma, avoid kinking. Forceful insertion is not allowed. You should be delicate as much as possible. Keep some gel foam, keep some fat by the side of the round window where the implant array is going, and make sure that patient doesn't develop meningitis, patient doesn't go for any infection. Impedance and NRTs are done in operation theater. We see the C-arm picture also, that implant is in place, and now we go for the problems which we can face is a facial injury, wound infection, dizziness, CSF leak. These are the minor problems, skin eruptions or heating because of the implant. This is a post-operative stitch infection. This is soft failure, which is very, very rare. Patient can have meningitis. This is really a catastrophic problem. Patient develops a post-oral abscess. Implant acting as a foreign body and biofilm developing. This is just because of the MRSA or Pseudomonas, that is methicillin resistant Staphylococcus aureus, and prevention is the only answer. Good asepsis, all disposable things, this will avoid the problem. Till this time, AVT is must. Now if AVT is not taken, our all efforts are gone. So AVT plays very, very vital role. Auditory verbal therapy for 1.5 years is given. There should be many, many efforts to do AVT successfully. And if we are able to do complete successful AVT program only, then only a cochlear implant is an successful event. Training for the surgeon, cadaver dissection is must. The team approach, anesthesiologist, radiologist, pediatrician, audiologist, philanthropist, ENT surgeon, family members, all are important. Surgeon's job is 10%, audiologist and speech therapist job is 90%. So what is new in CI? Totally implantable cochlear implant, artificial intelligence, drug-eluting electrodes, and gene therapy. These are the 4 important things which are important. The gene therapy about the otolaryngology, I just recently came, just a few weeks before, I came across a lecture whereby the gene therapy is being tried now for few malformations and which are showing good results. I thank you very much for organizing committee for giving me opportunity. Thank you.
Thank you, sir. I would now like to request the speaker to kindly come to the felicitation corner. I would like to request the organizing committee to kindly felicitate sir.
Someone ask questions, 1 or 2. You ask, because he is
You can ask questions.
Yes, 2 questions for this session. Vishwajit Gogoi is there. You ask questions, you are doing CI, Gautam, Kalpana, Gautam Nagi.
Is there any question?
Any question?
Yeah. Vishwajit, Dr. Vishwajit is there.
Yes.
Yeah.
It was a very excellent presentation. I was just one question for a junior colleague actually.
Yeah.
The indication of inclusion of cochlear implant is a optimal benefit or non-benefit with a hearing aid.
Yeah.
So how we objectify that this hearing is not benefited the child?
See, what is optimal hearing and what
No, sir. I'm telling this. I'm advising we have before implant we have always put the hearing aid.
Yeah.
But how will you objectify that this hearing is not the child is not getting benefited by the hearing aid?
See, the child is not having a speech, development of a speech, a recognizable speech. Sometimes child may say dada, baba, mama, like that, those words. These are just words which cannot be understood by everything. The word recognition is very important. So the speech discrimination, we do speech aided audiogram.
Yeah.
There is a aided audiogram and there is a speech banana which is there in the audiogram, and consonants and vowels are plotted there. So the vowels A, E, I, O, U, these are not very, very important, but child should be able to identify the consonants of the speech, because speech becomes meaningful only when the consonants are recognized. So if child's all uttered consonants are lying in the banana, then child will do with the hearing aid also, can do. But if it is far below the speech banana, then child is not up to the mark. That is how we objectify it.
Yes, sir.
I think I am.
Yes, sir, yes, I perfectly you have the, and I think, sir, also add on that the hearing aid should be optimized in such a way. It's
Yeah.
the highest amplification is we are putting to the child.
Yeah.
It's not like a simple hearing aid we are providing to the child, and we are doing all these speech tests so that we are giving a report card like this. He is not getting the benefit of it.
No, it's very, very recently, very, very developing science. When I started learning cochlear implant, I attended few of the lectures about the speech therapy by the speech therapists who were LS. It's a degree in the speech therapy which is of world recognition, and there was a morning for me because I was completely unaware about what the speech means and how we start listening in the womb of mother, and then we how many words should be. There is a lecture by our audiologist and speech therapist, 15 minutes talk at the end of this only, so you will know better, but it's very important that in last 6-7 years we have done 200 implants, and we can show the child who is implanted and speaking and the child who is just using the hearing aid. Suppose child who is implanted for 1 year and child who is using a hearing aid for 1 year. And if you see the speech of both the children, then there is a vast difference, and we can tell them to the parents, now see the difference yourself. So this is what is very, very important.
Thank you, sir.
Any question?
Yeah.
Sir, I'm Dr. Kumkum from Guwahati Medical College.
Yeah.
So, do you have any experience with hybrid implants in presbycusis?
Hybrid implants we don't have. There are certain patients who are having good hearing at some frequency, and some frequencies are so bad that the hearing aid is also not useful. And in that case, these hybrid implants are used. Just giving a rough idea, but I don't have any experience.
So, one more, sir.
Yeah.
If the round window is very posteriorly situated,
Yeah.
do you still go for round window insertion, or you want to do a separate cochleostomy?
See, there is these difficulties came for about 5-7 cases where we have to cut the posterior canal wall, and we have to fracture the posterior canal wall. So you saw that I had done a posterior tympanotomy. Just at the upper end of posterior tympanotomy, take a vertical cut till the uppermost end, and at the lower end of the posterior tympanotomy, take the vertical cut and fracture that and displace that posterior canal wall, bony posterior canal wall, little anteriorly. So that usually gives you the sufficient view of round window. Sometimes even this maneuver, if it doesn't give, then you have to do a cochleostomy, antero-inferior to the round window, and then you can place the electrode. But it's sometimes these situations are there. I agree with you.
Thank you, sir.
Thank you very much.
Sir,
I
one
think.
thing, this extended facial recess approach, is it you mean the fracture in the posterior canal wall
Yeah.
and then going more so that you can, even if the cochlea is rotated, you can approach to that
Yes,
area?
yes.
That is sort of extended facial recess only.
Yes, this is the extended facial recess approach, which you can call. There is one technique which is popularly known as a Verrier technique, and in that you do not need to really see any cochlear, this round window. You can, that is a different approach, and I don't have any experience of that.
Have you do any IQ assessment? How can you do IQ? If suppose the child has got no IQ,
Really,
then how the result?
there are different scores and different methods how the clinical psychologists go for IQ and DQ, development quotient and intelligence quotient assessment. But there are different batteries of the test. They give some toys and some few things to play. But that's a different science itself. But we grossly want to know whether child is mentally good or not. But nowadays the thought process is that even though the child has some mental challenge, why not to give him the gift of hearing? Because he already has 2 disabilities, at least take care of one disability. So this second disability will remain there. That is what new approach is.
Thank you very much. I think that I will conclude the session here.
Thank you.
Thank you, sir, for your. Actually, I should thank you for coming to Sipsagar from Aurangabad, because it will be injustice if I say that you had a wonderful speech, because everybody has seen that I, as an organizing president, I am just running from here and there. So I hardly have any time for the scientific session, but for the knowledge of the audience, actually we had planned a surgical workshop, and sir was supposed to be one of the resource persons. But unfortunately, because of the NMC rules, we had to abandon the workshop. But anyway, they had a workshop, nice workshop yesterday, but that was not associated with any BYD. It's our misfortune, especially for our postgraduate students. They could not see that. Anyway, thank you, sir. Thanks for coming to Sipsagar. Thank you.
There's an announcement. The 36th Annual Conference of Nebaoicon 2025 is going to be held in Agartala, Tripura on 25th and 26th October 2025. Our next speaker is Dr. N. Brian Shunyo. He is going to give a talk on translabyrinthine approach for vestibular schwannoma.
Actually, Dr. Brian, he is now the professor and HOD of AIMS, Sangsari, Guwahati. Actually, previously he was in HOD also, not HOD, in Negrims. Now he is a superintendent also, I think, you know, from AIMS. He is from MS, from All India Institute of Medical Science. And he can, you will surprise, he can do everything, every surgery. From pinaplasty to everything, fibular, head and neck, everything. So much talented man he is.
Thank you, Chairman Sir Phone Sir, for your introduction, and respected senior faculties, respected consultants, and all the delegates present here. First of all, I would like to thank the organizing team for giving me this opportunity to present my paper in the podium. Actually, a thought came to me that I should present this paper because few months ago, we did a survey. Then it is surprising to know that even our Apex Medical Teaching Institute in our country means many are not doing, our otologists are not performing the acoustic surgery. So a thought came to me that I should be presenting this paper. So this is more of a sensitization presentation to the resident doctors and the PG trainee doctors. So I hope I will not bore the rest. So acoustic neuroma constitute around 80% of the CP angle tumors and 10% of all brain tumors. The tumor is totally benign and is encapsulated and a extremely slow growing tumor of the 8th cranial nerve. And it is bilateral. This bilateral acoustic neuroma is seen in patients with neurofibromatosis. And the tumor arises from the swarm cell of the vestibular nerve and very rarely from the cochlear division of the 8 cranial nerves. The tumor takes origin from the nerve within the internal acoustic canal. As the tumor expands, it causes widening and erosion of the canal, and then it starts appearing in the CP angle area. Here, the tumor will grow superiorly to involve the 5th cranial nerve, and inferiorly, it will involve the 9, 10, 11 cranial nerves. As the tumor in the later stage, it can compress the brainstem. Not only that, it will start raising the intracranial tension. So, the classification of the tumor. The tumor is completely, grade 1 is considered to be when the tumor is completely within the internal acoustic canal. And the tumor size should be between 1 to 10 mm. Grade 2 is the tumor extend to the CP angle area, but not touching the brainstem, and the tumor size is between 10 to 20 mm. Grade 3 is said to be when the tumor extends into the CP angle area, touching the brainstem, but not compressing the brainstem, and the tumor size should be between 20 to 30 mm in size. Grade 4 is said to be when the tumor extends to CP angle area and compresses the brainstem, and the tumor size is more than 30 mm. This grading is little overlapping. We say grade 1 when the tumor size is 1 to 2, especially grade 3 and grade 4, there are a lot of overlapping is there. So you have to, these are not fixed, and different people have given different classifications. So we can follow any method of classification, but these are rough grading only. So these are brainstem tumor and are difficult to treat tumors. So what are the treatment options with us? One is wait and watch and follow up. And this can be done in a small tumor less than 1 centimeter because 20% of these tumors may not grow, or they may grow very insignificant over the years. And wait and watch policy also can be done in elderly patient with no symptoms. Radiation is another option with us, especially patients who are elderly and also patients who are having poor general condition. And of course, for the tumor size less than 1.5 centimeter. But we have to know that radiation is a bad choice for a benign tumor. And thirdly, surgery is the option behind. That is the third treatment option with us. So surgical intervention remains a viable treatment option for symptomatic or progressively enlarging tumors. And what are the surgical approach we have got? One is the retrosigmoid approach, a very popular and very versatile, time-honored neurosurgical approach. And second approach, we have got a translabyrinthine approach, yet to be popular among the otologists in our country. And middle fossa approach, this is the third approach available with us, but it has got a very limited indication, feasible only for the small intracranial tumors. So the choice remain with us is retrosigmoid or translab approach. So how do we decide the approach? See, the patient factor has to be taken into account, and the tumor factor also has to be taken into account. These two factors have to be taken into account when we choose the approach. Yes. Yes, okay. And so coming to the patient factor, hearing status of the patient preoperatively very important, and the facial nerve status post-surgery by which approach is very important. And the tumor factor is the size of the tumor is very important, and degree of tumor extension into the internal aqueous canal. That is the lateral extension of tumor, so it has to be taken into account when we choose the approach and the involvement of the brainstem. So one by one we'll be going into the approaches. The factor to choose the approach. Does the size of the tumor, does the size of the tumor decide the approach? See, by translab, this is not working. See, this is by translate approach. See, this is the window will be getting the right side of the thin. This is the translate approach. By translate approach, we'll be getting this window or the corridor will be getting the arrow marks. So it gives, and this is totally without brain retraction. But of course, we have to do a lot of bony work. Bony work we have to do, but this is the access we'll be getting by translate approach. There's a good, it gives a very good exposure of the tumor of the lateral extent, and also it gives a very good exposure to the medial extent of the tumor. We can see from there. On the right side, this is the retrosigmoid approach. The arrow mark, this is the window. After doing a craniotomy, then after doing the brain retraction, the cerebellum has to be retracted to get the retrosigmoid approach. And that we have to do a kind of, this is really a bit, severe brain retraction has to be done, especially the cerebellum has to be retracted to get this approach. And see, it gives a very good exposure of the medial part of the tumor, but it gives a very poor exposure to the lateral part of the tumor. So the size of the tumor does not decide the approach. Even the very large tumor can be removed by debulking and piecemeal removal. So the size of the tumor is not going to decide the approach, because most of the time when the big tumor comes, we're always afraid that through the year it is not possible. The thought comes to us suddenly that it should go to the retrosigmoid approach, which is the basic, which is the time-honored neurosurgical approach. So this is one of the fallacy we come across, but it is not the size. It is by the approach. It's we can see from here the approach. Translab also give a very good approach. So the lateral extension of the tumor. So the lateral extension of tumor, that is tumor in the internal aqueous canal matrix with tumor complete removal. This is the right, the left side is this one, aqueous tumor of the left side going into the internal aqueous canal. And the other side, the right side, that is the aqueous tumor of the right side, where there is a limited extension into the internal acoustic canal. We can see the fundal CSF. No, we can. The arrow pointer, no, then. See, we can see the fundal CSS gap. So it indicates it has a very limited lateral extension. So if given a choice, the right side tumor, the right side acoustic tumor can go for retrosigmoid approach if provided the patient a good hearing status preoperatively. And the left side tumor, yeah, no working, but so yes, sir. But the left side tumor, the tumor going to the internal acoustic can definitely need translate approach if you want to remove the whole tumor. It's okay. Coming to the facial nerve, no working. Coming to the facial nerve, like the MRM, the acoustic surgery is all about facial nerve. In translate approach, see, the facial nerve is first identified. Then the tumor removal begins. We can see from here, once we have done a laminectomy and the internal acoustic canal is open, the first thing we do is identify the facial nerve. Then the tumor removal starts. So the facial nerve is traced from the beginning of the surgery and is constantly under revision throughout the surgery. Whereas if you see the retrosigmoid approach, see the facial nerve is not directly under the surgeon control. In fact, the tumor will be coming between the surgeon and the tumor. The tumor will be coming between the surgeon and the nerve. That's why the retrosigmoid is associated with a very high facial nerve injury, and compared to translap, which is associated with a low facial nerve injury here. There have been many studies being done, many meta-analysis have been done comparing the retrosigmoid with the translate approach. And this is one of the studies which came out in 2015, meta-analysis taken from different centers all over, many important centers they have taken. And it has come to a conclusion that the retrosigmoid is given, this study showed that retrosigmoid is given a post-facial nerve injury of 18.7. Comparing to translate, we give 2.6 post-surgery facial nerve injury. I think this is a very important take-home message for the otologists for translate approach. Hearing preservation. When we say hearing preservation, then retrosigmoid approach comes to us. There is a notion that retrosigmoid is a hearing preservation surgery, but we all do know that acoustic tumor arises from the inferior vestibular nerve, and inferior vestibular nerve and cochlear nerve lie in contact with each other. So any tumor bigger than 1 centimeter or nearing 1 centimeter is definitely arising from the inferior vestibular nerve, is definitely going to cause hamper the function of the cochlear nerve. So a patient may come to us with mild hearing loss, but if you do the STD, that is speech discrimination score, we will get a poor or very poor speech discrimination score. So we have to, as I told you, we have to know that useful serviceable hearing should be viewed by the speech discrimination score rather than by PTA. Other complications associated with the approaches are like CSF leakage is the same for the retrosigmoid and translate. This is more to do with the meticulous closing rather than the approach. So the rest are minor, like these are minor things, and the approach doesn't make any difference with the other complications. So translate approach is not inferior to retrosigmoid in approach. Why then? We have to ask one question, why then? Retrosigmoid is still the most common performed surgery for acoustic tumor in our country. I think there must be many reasons, but we as an otologist, I think we need to retain and popularize the technique, because I feel this is within our domain, and I think we need to popularize the technique. As I told you, I think we can defend. I think we should be able to be, and the translate gives such a good approach rather than retrosegment. So as an authority, we should popularize that technique. This is few steps of translate approach. This was a patient we operated last Monday. See, we give skin incision, 4 centimeters behind the pinna, little more than we do for the normal MRM. And we reach the skin flap, and then we do cortical master. My time is 15 minutes. Yeah. So cortical masterectomy is done. Then we do exposure of the middle cranial fossa. We do exposure the middle cranial fossa, and then expose the treatment sinus also, so that we can decompress during the surgery. Middle cranial fossa need to be decompressed during surgery for tumor exposure, and then we need to get sigmoid sinus need to be exposed, and then after that we do labyrinthectomy. But before opening the internal aqueous canal, we have to create a superior and inferior tuft. There is superior tuft and inferior. This is superior and this is the inferior tuft need to be created before we open the internal aqueous canal. This is a short video we operated last Monday. Audio is not coming. This see, we open the internal acoustic canal, and this is the so this is the superior vestibular nerve. Audio name. छोड़ो कहाँ ऑन छोड़ो भाई यहाँ फॉरवर्ड कैसे करेगा वीडियो थोड़ा फॉरवर्ड करना है वीडियो थोड़ा फॉरवर्ड करो ना आगे करने के लिए वीडियो the time so sorry I couldn't show the whole video of short time. So the cavity is obliterated with the fat harvest from the abdomen. This was our patient. Of course I've shown the fat, but I've taken permission from the patient. So it gives a very good result. You see, mild facial palsy is there, but it will improve. So, point for the translator approach. Vertical facial nerve need to be delineated or skeletonized for proper exposure to the cipiangle area. Jugular bulb need to be delineated well. Inferior and superior tuft need to be created before opening into the IAC, and a plane need to be developed between the tumor and arytenoid to safeguard the vessel and the nerve head. This was our paper published in 2021. On regard to the aquestic neuroma, this our statistic we have been published it. And case scenario, what do we learn? Patient coming to you with facial nerve injury pre-operatively. These patients should be referred to retrosigmoid approach, because retrosigmoid is a very fast surgery here. Translate has got a lot of bony work to be done, and it's a very long surgery. Tumor removal will take a lot of time, sometimes 2-3 hours altogether. But translate is a very quick approach, and patient coming to with pre-operative facial nerve surgery, they should be referred for post or retrosigmoid approach. And patient comes to with severe ataxia, or patient is brought to you with in a stretcher, better refer them to neurosurgery, because post-surgery these are very difficult to manage. Anything going wrong with neurosurgery, patient will take it. Thing going wrong in the hematology, patient can create a lot of problems. So this patient, we better refer them to neurosurgery, because they'll have a lot of other complications. Post are very difficult to take care. And patient operated earlier and coming to you with recurrence, there's a big problem. So these people also are not fit for translate approach, because you will not get a plane. We had some experience. We had one experience with one patient. We tried to operate. There was a lot of lesion. We could not identify any structure. So in this kind of case, we are surely going to injure facial nerve. So they are better referred to neurosurgery colleague, or another option is they can go for radiation. So in conclusion, a patient properly selected translate provide the best approach to patient in terms of facial nerve preservation and complete tumor removal. Thank you all for your patient listening.
Thank you very much, sir. It was very wonderful talk. And
So sorry I couldn't present the video. I think the time was a little short.
yeah, it was a very long topic, but you still covered it. Yeah.
Yes, sir. Initially, actually, we started doing this surgery because initial of earlier means neurosurgery used to call when there's a aquatic tumor initially. Then we started assisting them, and then we came to know that they are struggling post-retrosigmoid. That's how the concept came to other. We should see something. Then that's how we started doing translate. Initially, then we were doing combinedly, but now for few years I'm not calling neurosurgery because neurosurgeries are very good, but at the same time, see, for them we are very afraid of small bleeding. For them they will be very far. They are not at all afraid. And then facial nerve injury for them is not a big deal. For us to see as an otologist, we want see result is more important than removing the tumor. We want to give very good result to a patient. We have a few cases we were doing neurosurgery, but complication facial nerve is they will come. They will remove the tumor very fast. But we are very meticulous. We want to be very meticulous, and we take tumor removal. Very big tumors can be removed, but so we have to cauterize, remove, and debulk. Then let the capsule collapse. Then you create a plane between the renal and tumor, and then you dissect. See, it is a very time thing. You have to be very patient. Aquatic surgery here. So when we want minimal bleeding when removed, so the complication doesn't come. ICA had to be identified and then preserved, or a brain stroke can happen. But neurosurgeons are not they are very good, I said, but at the same time, see, we want least complications. So now we are not calling them, but we always call them when needed be.
Suppose tumor size is very big.
Yes, sir.
And your speech discrimination score is good.
Facial nerve.
The SGS is good.
Yes, sir.
Then what will you do? Then that's the way that you do.
No,
Hearing is good. Suppose hearing is good. Your speech discrimination is good, more than 50 or 60. Then tumor is but big.
but that scenario will not come, sir. That is
Issue?
not possible.
Not possible.
Practically not possible, sir.
Not possible.
Any bit, say, any tumor crossing 1.5 centimeter is going to have a very poor speech discrimination score. They practically not possible, sir. Theoretically, you are saying, but practically it cannot be like this, sir.
Vishwajit has some experience with this. Recently has done with some neurosurgeon. Can you ask some enlighten?
Sir. Yeah, excellent again, excellent presentation, sir. Vestibular schwannoma I would count, sir, also. But most all our tumors we are always with a neurosurgeons, practically speaking. I have not single cases we have not done by ENT only, and mostly they have called us, not we have referred to them actually. And Translab I think we have done 4 till date. And sir, can I ask one question?
Yes, sir.
In parotid we have a landmark for facial. Mastoid surgery we have a landmark for facial. Can you give a tips in schwannoma cases, this vestibular schwannoma? What is the landmark for labyrinthine portion of the facial nerve?
Labyrinthine portion we don't identify. Initially, see, when you go to the house, William house, they identify labyrinthine portion they started. But Mario Sana never do that. So we don't have to identify the labyrinthine portion of facial nerve. Go to the open identify the transverse crease and vertical crease. It's just in front of you here. Basically, aquatic surgery is not a very we are basically as an our mind is blocked. When we actually this is a brainstem tumor and of course brainstem tumor and very delicate structure, very delicate surgery. But you open the IC. And then you identify the vertical crease, or horizontal, vertical. The facial nerve is just there. And from there you start tracing down. We remove that portion, lateral portion first, then debulk the tumor. Then after that, we started going deeper.
So
we have to go.
You start from the superior vestibular.
No, see, deep within below the superior vestibular is the facial nerve. The
Yeah,
first
that-
thing I did was superior vestibular nerve.
That's what I want to highlight to the juniors. The superior vestibular, you first want to
The
identify.
more, this is the landmark.
This is the landmark. But thank you so much.
Cusack, neurosurgeon, that's why neurosurgeons are, see, I'm not afraid to call neurosurgeon. Why? Because they'll come and remove Cusack, very fast there. They don't have much time. We spent 3-4 hours or so. Last Monday we operated, we spent 4 hours removing the tumor. But patient no complication. Pardon?
Kusa, the instrument used by neurosurgeon.
The cautery. The cautery had to be civil coated. Cautery, remove cautery, remove cautery, remove cautery, remove. We had to spend 2-3 hours or so. And then let the tumor collapse. When the tumor collapse, you'll get a plane. Initially, the video cannot be shown. Initially, you will have a problem with the cerebellum will be coming to your field. Don't worry, keep on removing. A cerebellum will shrink. Initially, cerebellum will come into your field. You will get osteoarthritis. Keep on removing the tumor. After some time, after you keep on removing tumor and adenoid being separated and system being open, CSA drain out there, automatically cerebellum will not come into the field. Initially, you will feel, oh, I will not be able to see deep down. It is not at all like that. So we have to have a lot of patience, keep on removing. Patient is ultimately with this tumor.
Okay, then why were giving the nomenclature acoustic neuroma? Now
Pardon?
is a acoustic neuroma.
Yes,
You
sir.
have- Now is a vestibular schwannoma. Nomenclature.
Yes, sir.
That you're, therefore I have taken acoustic.
Yes. Yes, sir.
Okay, thank you.
Okay.
I conclude the session. Yeah.
We are delayed by 1 hour.
Thank you very much.
Can you sum? We are delayed by 1 hour. I
1
cannot-
hour.
1 hour delayed already.
No, you have really done a very good job.
Oh, sir.
I was in London and there was a Dr. King, he was a neurosurgeon.
Yes, sir.
Dr. Morrison was the ENT surgeon.
Yes,
They were
sir.
very good friends.
Yes, sir.
All these operations were done together.
So we also do together.
Yeah, better.
Yeah, we also do together. sir.
That's why I am telling, it is better.
Yes, sir. Yes, sir.
It is better.
Yes, sir.
Our
Thank you. I think
next speaker is Dr. Anupam Hazarika. Please come to the stage.
Dr. Anupam Hazarika is going to give a talk on the topic Hopkins rod in middle ear cleft, flexibility of techniques and their applications. Please welcome on stage Dr. Anupam Hazarika.
Hello. Honorable moderator, sir, may I have your attention, please? As you can see, we are running much behind our schedule. So kindly make the question answer sessions very little shorter. Otherwise, it will be very difficult. Otherwise, we'll end this session by about 8:39. Then we'll not have any time for anything. Kindly try to be in time and let's make the question answer session little shorter. I'm sorry. Basically, this kind of conferences are only for academics. I understand, but problem is that we are having lot of time constraints.
Yes.
So I'll request everyone. Yeah, no, I understand, but this is a request from the organizing committee.
Yes.
This is a request. Please don't take it as anything else. Just a request.
Yes, sir.
A very good afternoon to all of you. Hope I'm able to keep your heads up with the head-up technique, which is the Hopkins rod in middle ear cleft surgery, respected chairpersons and the respected delegates. So if we go back to the evolution of ear surgery, it has passed through 3 stages: the trepanage, the chisel gouge, and the drill and microscope age. And then the development in ear surgery has taken place over the last 2 decades. Disclosures, nothing, no financial disclosure. Our philosophy and concept of starting with the endoscopic ear surgery was based on the fact that if Stemberger could preach the face, we could preach the T's and the Femis. by preservation of healthy medullary mucosa and establishing the ventilation pathways. And in our own comparison study, we have found that cortical mystoidectomy that we have done in a few cases, in 80% cases, we have found that there is practically no disease in the antrum. Most of the disease is confined to the proximal editus, and there are exceptions, of course, for which we have to go ahead with cortical mystoidectomy. This is the relevant anatomy, and it is centered around the posterior supratic, the editus, proximal editus, and the anterior epitympanic space. And these are the conditions favoring good outcome: a good history with inactive disease before operating for approximately 3 months. If you can wait, the results are guaranteed to be good. And to achieve this, we have to work on the ventilation pathways, mainly the isthmus anticus posticus. We may have a tensor fold, which is patent in some cases. Then we have the eustachian tube, of course. Can we do a pure transcanal approach in each and every case? Probably not, but we do make an effort, and through the 3 mm 140 degree 0 degree endoscope recommended by International Working Group, we have seen that most of the canals are manageable. So these are the tools that we have: effective bone cutting tools, the angle instruments. We have designed about few instruments from our own by bending the tools. Endo holder if possible. This is not a must, but if we have in place, it works well. We had our own endo holder design, and globally India was the pioneer in the first international congress, and my endo holder, which I designed, got its patent last year. So this is a endoscopic surgery we operated for ventilation defect. On one inset we are seeing a retraction pocket, on the other inset we are seeing a surgery being done where the patient came with a facial palsy, and radiologically it was showing that the disease was aticoantral, and there was no comment on cholestotoma in the radiological reporting, and we decided to go transcanal. And what we observed in this picture is that here we found a ventilation defect concerning the editus, and this is a technique we apply to see the depth as to how deeper we can drill. So we can see here there is no evidence of cholestotoma here. It is all a mucosal disease, and this basically arises because of a chronic ventilation defect. And in the other inset we see that there's a retraction pocket where we have taken off the adhesion from the retraction pocket, working around the ossicles. The stapedius diagram you can see here, then dissecting the adhesive mucosa around the incudostapedial joint. So this was a bony defect that we curated out, and we did a minimal soft wall reconstruction for this defect. So here we can see there was no disease beyond this, and this is a healthy mucosa coming in around the proximal editus. So the retraction pocket was confined basically to the proximal editus only. This is a bone nibbler we are using to cut the bone in the posterior superior to find the way to the proximal editus. And in the other inset we can see we have inspecting the whole of the antrum through the opening that we created here. We did a irrigation with the ringer's lactate, and there was no evidence of cholestotoma here. So probably we can say that it is a existence of a dual situation where the facial paralysis was probably a Bell's palsy. These are the results. We had a 20 decibel closure of the airborne gap. Then endoscopic ear surgery can be applied for the dealing with stage 2 cholestotoma where disease is confined to the atic. So, the granulations, residual granulations were removed subsequently after removal of the cholestotoma sac. This is a combined approach tympanoplasty where for stage 3 cholestotoma we have to keep our minds open and keep it whether we can go post-auricularly or transcanally, and if we can go together both the ways, probably we can do a more physiological surgery by preserving the posterior superior canal wall. We did a vertical umbrella reconstruction over the stapes head, and this is a technique where we have done an exoscopic technique. The exoscopic technique is nothing but we hold the endoscope away from the depth, and this is a surgery done in 2012, stage 3 cholestotoma, and recently this exoscopic technique was published in Otolaryngology clinics by an article was shown where they have applied exoscope during the COVID period as a head-up technique. So here in this patient we do the reconstruction after removal of the cholestotoma with a vertical struct, and this is a cartilage space directly into the oval window niche where the head was missing. Endoscopic ear surgery for the revision cases. Most of the times patients do not like the repeated post-auricular incision if there is a recurrence, and if we can manage to go transcanal, this is definitely a benefit for the patient, of course. So in this patient, patient came with a facial palsy, dehiscent facial canal with the facial nerve exposed. There we can see the facial nerve. There was a bonius spicule where there was granulation. So we did a transcanal procedure, removed the disease around the lateral semicircular canal, granulations. These patients we put on prolonged steroid drops. Transcanal endoscopic ear surgery applied to the total annulus excision. This is of course a new and recent concept being applied by Suri Prabhu et al. They emphasizing on the total discarding of the annulus, and they have advocated for each and every case. But to our experience, we see that it's basically an overdone procedure if we apply for each and every case, and basically for subtotal perforations where there is just a peripheral rim of the tympanic rim. In those cases, if we operate, okay, we can justify that epithelial immigration underneath the tympanic remnant is not going to occur. In the other inset, we are doing a interlay tympanoplasty, and here we can see we are separating the 3 layers here. The bony annulus and the tympanic annulus is being taken out from the bony sulcus. There we separate the mucosa from the tympanic remnant. So laterally you have 2 layers. The tympanic middle layer and the epithelial layer comes out, and we leave behind the medial most layer, and we put the graft with the lateral to outside and the medial one inside. This is my one and only experience with a stapes surgery, and it's a very difficult task taking the patient from the clinic to the OT. That's a very difficult task, and especially convincing a patient for stapes surgery with all the pros and cons, explaining to them that you may go deaf even after surgery. It's very difficult, and this was my one and only stapes surgery, which I felt like abandoning midway, and with the supporting OT stuff, I managed to complete it. Patient is hearing well at presently, and it may be called a beginner's luck. So the patient still is in. They put the piston, struggling very much. Finally. So we have done we waited to call our study evidence-based. So we waited for at least a mean follow-up period of 4 years, whom we tried to keep under our follow-up, so that we can see that what we are doing is correct, especially with the concept of going transcanal first. And we got our original research article published in 2023, and there we have mentioned about that the cortical mastectomy basically is an overdone procedure in each and every case, and we should follow the new concept that we should go transcanal first, and if indicated then go post-auricularly. These are few results. So surgically, if we see, we get a satisfactory result from the application of endoscope, from the decrease in the residuals and recurrences, and graphic uptake level is more or less equivalent even with the microscope pick techniques. Cosmetically, of course, better if we go a transcanal procedure, and likewise the post-operative morbidity is less. So this is the concluding slide, where I have picked up a snapshot from the otolaryngology clinics of North America. There they have emphasized on the 3 stages of the evolution of otologic surgery. The first being the trepanese, the second being the chisel and cows, third came the development of the microscope, and then came the endoscopes in the late 90s, and where John William House himself has said that perhaps endoscopic ear surgery is heralding a 4th phase, wherein the indications for mastectomy become more limited. Thank you for your patient listening.
Yeah. Thank you, sir. Any questions from the audience?
Thank you so much.
So I think we can.
Our next speaker is Dr. Dhanashree Bhisegaonkar, who will be speaking on auditory verbal therapy for children with cochlear implants.
Hello, hello. Hello, hello. Hello, respected chairperson and vice chairperson and delegates. I would like to thank you to Nebaoicon for giving us such a nice platform for me. I am Dr. Dhanashri Bisegaonkar. I am working as an auditory verbal therapist and special educator for more than 11 years with the focus on mainstreaming and education of CI recipient. I am consultant and habilitationist at the Kimia Cochlear Implant Center, Hedgewar Hospital, Aurangabad, which is now a Sambhaji Nagar. Dr. Bharat Deshmukh and me working in a same Kimia Cochlear Implant Center. Dr. Hedgewar Hospital also runs the Sukafa Hospital, which is in now Shivsagar. So I would like to take your attention to this video. So this video is in Marathi. He is a cochlear implant child who is implanted at right age.
आणि इथे काय दिसतंय हम्माचे कान हे बघ हम्माच्या गाण्यामध्ये घंटी दादा आला हे बघ हम्माच्या गाण्यामध्ये कशी घंटी आणि ईशानच्या गाण्यामध्ये काय आहे.
So this video actually explains the cochlear implant who is for a right age, right CI, right age, and with regular AVT therapy. So the outcomes within the time frame is like this. So this child is like a normal kid who have who is understanding the right intonation patterns and the speech understanding. So this is a concept of next slide. This is a concept of 46 million words. So today's my topic is AVT, that is what is an auditory verbal therapy and what is the concept of auditory verbal therapy. So this is a concept of 46 million words. So habilitation by auditory verbal therapy of a 4-year-old child who has undergone cochlear implant for whatever reason of getting implanted late is based on the concept of these 46 million words. As compared to a normal hearing of 4-year child going to preschool, our post-CI 4-year has a gap of hearing of 46 million words. This calculation is based on a normal child hearing about the 1,371 words per hour. So that is 16,438 words per day and about 60 lakhs words per year. So these numbers speak themselves and the importance of the earliest intervention possible for a CI candidates. So interestingly, research by the Dehen says that at least 20,000 hours of listening is important before the child can start reading. It means as compared to a normal child of 3 to 4 years who has started reading a few words, and the child with a CI done at 4 years not only can't speak but his reading milestones are also affected. We need to understand that at 4 years a normal child not only should be able to read but also understand and comprehend what he and she is reading. An implanted child for 4 years might be just copying the therapist or the parents and not comprehend what he or she is reading. This is not enough. So to make it short for our understanding, there are a lot of tasks that we need to done by late implanted 4-year-olds to make them include with their normal peers at preschool. At Pittman's research says a child with hearing loss requires 3 times exposure to learn a new words and concept due to reduced acoustic bandwidths. So it is caused due to a hearing loss. So what is the main idea behind the habilitation of cochlear implant? So the hearing is a first order event for the development of a spoken communication and literacy skills. Anytime, if the children are below 3 years and we should facilitate the learning through auditory brain, then only the child can learn the language and go to a regular school. To make this possible, the acoustical accessibility of intelligible speech is essential for the brain development. And this is only possible when the therapist can make use of intelligent sound reaching the auditory cortex through a good CI. There are the skills and strategy to facilitate the auditory brain development of the child. So, when we say auditory verbal therapy, so the questions come in our mind, so what it is, why we should do it, and how can we implement the auditory verbal therapy for CI patients. So the auditory rehabilitation program, provides a systematic instructions to hearing impaired children so that they learn to process the speech and language through audition. The AVT contains a set of lessons. Every lesson is planned. It is not just sitting and playing with the children, and the therapist has to plan a particular lesson with a clear goal of what they expect from the child. How they communicate this with the child, plan for the tools to use to get it done from the child. It is even more interesting and challenging to make the sessions customized for the particular child with respect to his capacity interest while taking care of his or her tantrums. Therapy has to be purely verbal, no gestures are to be used. Our goal is to include the verbal language and not one with the gestures. So what does it take to have a listening and spoken communication outcomes? How do we exactly do AVT? How do we develop a spoken language to engage a professional who is highly qualified and trained in the development of the listening and speaking through the techniques of parent coaching? There is no full stop after that. We have to employ strategies that grow the baby's brain, which is both an art and the science at the same time. There is a lot of theoretical knowledge about the stages and strategies of listening and speaking development of a newborn, so which is now easily available on internet too. But the challenge is how to employ it, and we have to use it through the parents who are not professionals. Our aim is to develop the auditory brain of the child whose auditory brain is already shrunken due to the hearing loss. Deaf-mute child's auditory brain cortex is encroached by the visual brain cortex, so that the child is naturally prone to use the cues and the gestures. As Dr. Bharat Deshmukh said that earlier in their slides, so use it or lose it. So if the child have a hearing loss, so the visual area is more prominent for the communication. So this deaf-mute child is more actively they do the gestures and they communicate through the gestures, and they more like to do it. It is natural due to the encroachment of that visual listening area on the visual area. So why we are doing, what does it take to have the listening and spoken communication outcomes? So the purpose of all these hearing aid, cochlear implants, FM auditory verbal intervention is to grow development of an auditory brain. The concept of 46 million words. So the basic neural research offers increasingly the robust information about the neural plasticity and about the necessity of accessing and stimulating auditory brain centers early and often. There is a science behind the practice of AVT. So how can we implement these strategies? So parent or the caregivers and the family members are the best people to develop the spoken language through listening in the house in the natural environment. By the ABT we exercise the stimulating and stimulate the brain centers. The ABT is systematic method. We do it through the parent and sometimes through the caregivers, because sometimes parents are also have hearing impairment. So it is an amazing amount of practice is needed to influence the neural structures, and only family can provide the necessary amount of patience. We know our neural structure, it works together through the reinforcement which happens by making a new synapses. A trained and a knowledgeable therapist can be a professional, specific educator or audiologist who know whose synapses what is the synapses strengthening, how to increase it. They know how to build a brain library. They know how a child learns from 0 to 6 years of age, how to use an executive functions of the brain to develop the spoken language communications. So synaptic strengthening, building of a brain library, theory of learning, executive functions of the brain. The role of attention is more important in the auditory verbal therapy. So the strategy, what we'll see, there are two parts in the auditory verbal therapy, that is pre-operative auditory verbal therapy and the post-operative auditory verbal therapy. So in pre-operative verbal therapy, we generally, it is useful to encourage and evaluate the early communication and pre-verbal skills. So pre-operative verbal therapy sessions gives an opportunity to familiarize the child and the family with cochlear implant issues. So the child and family will develop the rapport with the professionals involved in the post-op habilitation. We have to make the parent understand how important their role in the future journey. The child will get used to wear something on the ear and will not reject wear a speech processor after post-op, so that he or she will use the device for maximum time, which will further reduce the time of the child to get the good outcomes. So pre-operative therapy will also help to develop the child's habitat of listening. So in post-operative therapy, the goal of the post-operative therapy is to encourage the confidence in the cochlear implant signals. It starts with the switch on, which we do once the wound is healed after 2 to 3 weeks of post-operative. Switch on is followed by giving a primary map to the processor, and remapping process goes hand in hand with the post-operative therapy with the suitable intervals. In post-operative therapy, we have to encourage the maximum use of the device. We have to convince the parents about it. Often parents remove the external devices when child is tired, but it is not good for the patient, that child. So in post-operative therapy sessions, we must have a realistic time frame for achievement of the goals. So this realistic time frame develops on the many factors. So what are the factors that affect the outcomes? So age of the diagnosis and implantation, how the audiologist management is done, what is the emotional state of the family, for example the grief period of the family, the rejection of the child to wear the processor and hearing aid, what is the child's intelligence and the learning style. Sometimes child also have some other medical issues, for example child can be a hyperactive, sometimes it has a autism spectrum disorders. So the skill and the knowledge of the therapist is also plays an important role. And सबसे important I must say the family participation, how much the family is participating, their support, their regularity of the post-operative therapy sessions, and how intelligently they working on the lessons at home. So these are the main factors I would like to share with you all. So I have two videos. So the one video I just want to share. Yeah. So in first video, we expect the first 6 months journey that the baby is get to use the sound processor, and without any gestures, his auditory brain is developing, and he's followed me and the repeated the link 6 sounds by without any gestures. So I would like to play that video for you, sir. Just a minute. So this is a proverb. So the children with hearing aid or cochlear implant aren't sent to a special parent. They make a parent special. So this is a video. So this is a high frequency sound. Even within a 6 months of 2 to 3 months of a period, he is able to imitate the Link 6 sounds. And in another video, the therapist is sitting with the child, and he's just added his vocabulary, and he's added the words to the his speech and language. So he's telling story about the balloon. I'm very sorry, it is not audible, I think.
हवा का निघाली नंतर शिवण्याने म्हटलं आता काय करायचं शंभू म्हटला आता फुगा फुगून
Thank you. Thank you all of you for listening patiently. Thank you.
Thank you, Dr. Dhanshri. It was very wonderful and eye-opening
you.
for us. Thank you.
So I would like to request our speakers of this talk session, Dr. Anne Brian Shunyu, Dr. Anupam Hazarika, and Dr. Dhanashri Phisegaonkar to kindly proceed towards the felicitation corner. And I would like to request our chairpersons to kindly come forward and felicitate them. Awesome. Now, I would like to request Dr. Fawzia Shireen Hakim ma'am to please come forward and felicitate our chairpersons.
Next, we have our otology panel on the topic tympanomastoid surgery. The moderator is Dr. Bharat Deshmukh, and the panelists include Dr. S.B. Phukon, Dr. S.N. Mukherjee, Dr. Kumkum Bora, Dr. Abhinava Ghosh, Dr. Ranjan Nath, Dr. Nabarun Das Gupta. The panel will be of 30 minutes. The panel discussion will be of 30 minutes.
I request all the panelists, respected panelists, Dr. Phukon, Dr. Mukherjee, Dr. Bora, Dr. Das Gupta, Dr. Ranjan, and Dr. Ghosh. Please. Yeah.
He also become promoted to moderators.
So let us quickly start as the time has been reduced by organizers. One more chair is required, I think. Two more, one more chair. One more chair.
We have a small announcement. If anybody wants to get the life membership of Neboi, the registration fees is rupees 5,000, and for associate membership, the registration fees is rupees 2,000. And if anybody is interested to get the life membership certificate, it's available in our Oskin Care stall outside. Thank you.
I thank you, the organizers, for making me the moderator for this session. I am very happy that I am given this opportunity in place of Dr. Roy Chaudhary, and I don't know how I'll work as a stepney or stopgap arrangement, and the panelists are very esteemed panelists today, and we'll make the discussion a little interesting by making a quick round of questions on different aspects of tympanомастодectomy. Tympanoplasty and mastodectomy is very interesting topic, and day to day we all deal with the questions, so it's of importance because everyone has some connection with it. Now the first question to Dr. Fukan, in your opinion, what is the difference between myringoplasty and tympanoplasty?
Actually, thank you very much the organizing committee for giving me instant opportunity to become a panelist, promoted by panelist. And you also promoted a moderator.
Yeah, I am promoted today as a moderator.
And actually, in my thinking, not my thinking, is the principle actually, the myringoplasty versus tympanoplasty. Myringoplasty is a type 1 tympanoplasty, purely on the grafting procedure, and tympanoplasty has got some types according to setup of the middle layer, ossicles and other things.
Yes, yes. So anybody differs with opinion of Dr. Fukan, or everybody is in line with that? You have something to say? Please.
So actually, for tympanoplasty, I think we should go for the disease clearance. Even the mucosal clearance from the middle ear and the mastoid. And it may or may not be with ossiculoplasty, but we can definitely with an underlay tympanic membrane grafting. But some sort of disease clearance we used to do in tympanoplasty.
Maybe tympanosclerosis you want to focus, maybe like
tympanosclerosis, then recurrent otitis media, not responding to your usual.
Do you also mean that sometimes in tympanoplasty you go ahead and do cortical mastodectomy, and in myringoplasty you don't do it?
Yeah, exactly. So there are some conditions where we go for intracanal mastodectomy along
from the mastoid region. So we'll move to the next questions, and how you will decide that this patient so we'll take all these three questions now. If once we decide that we want to do an myringoplasty or tympanoplasty type 1, do you give any importance to whether the ear is dry or not, Dr. Mukherjee?
Not necessarily, actually. It need
So
not
you
be dry.
operate on the wet ear also?
No, I also operate on the wet ear, provided it is only simply mucus. No infection is there, and patient doesn't have any upper respiratory tract infection as such. In that case, even in slight wet ear also, not obvious, not copious, just like moist ear, we can operate.
Do you operate, by the way, if there is some fungus, dry fungus in the external auditory canal?
No, definitely not.
No.
If there is a fungus or there is an active infection in the middle ear or but say in the canal itself, because then our whole effort will be in vain.
Anybody differs from his opinion that essentially if there is a very slight discharge, he will go ahead, and if he will not would like to have a nil discharge before doing a myringoplasty or tympanoplasty type 1. And I know there are some people who want very, very dry. If anybody differs, please, you can go ahead with your views.
Sir, in my practice, I usually prefer dry ear.
Right.
I gave 1 week or 10 days conservative therapy prior to surgery. But if the ear fails to dry, even after conservative treatment, I go ahead for the surgery. But in those cases, I open the mastoid and see the patency of editas. Then if somehow, sometimes accidentally, there is some dry fungus in the external auditory canal on the operation table, then I don't cancel the case. I thoroughly irrigate with betadine for 5 to 10 times. Then I go ahead with surgery.
Yes.
I don't cancel those cases
Yeah.
of accidental fungus.
Is anybody who is of any different opinion? Yes.
I use acetic acid also.
Acetic acid.
And betadine both.
Yeah. So I have also heard there are some people who have acetic acid, then they have some Savlon and then combination, and they give douching and try to make the ear dry, because many times you try giving lot of antibiotics, ear doesn't become dry. What to do is really a tough question. I think Dr. Ghosh, you want to say something? Anybody? Both of, one of you.
Sir, what I practice personally is, in all the cases, if there is wet ear, I give antibiotic and steroid for 3 days preoperatively in all the wet ear cases, and then I operate. I just make it sure that if still there is discharge, I do a mastoidectomy and I look for the patency of this editus.
Yes. So he is like we call it as a control whore or cortical mastoidectomy. He is a proponent of that. Anybody who regularly goes or thinks and that cortical mastoidectomy is must before doing tympanoplasty?
Sir, in my practice, I don't do cortical mastoidectomy in each and every case of myringoplasty or tympanoplasty, but I just open the mastoid, and if I get few cell and if water is freely flowing, and that assures that the editas is patent. So thereafter I do the grafting.
Yes. Yes, doctor.
There is some literature also. The doing cortical mastoidectomy and myringoplasty type 1, the results are same.
Yeah.
Unless
Yeah.
there is some literature.
In fact, one of my PG student has done a thesis on that, and as you say, the final outcome was same. The take-up graft rate and even the hearing gain was same. That is apart, but personal variations may happen.
So regarding doing this cortical mastoidectomy, there is some indications we follow where we do not open up the mastoid. Number one is a very dry perforation with an ossicular necrosis. With a completely dry middle ear mucosa, we do not open up the mastoid. Then traumatic ear perforations with ossicular necrosis. Congenital ossicular discontinuity. Now these are the cases where we know that the etiology is not mastoid, it is rather a trauma or something else. No need to open up the mastoid. But yes, recurrent otitis media, which is not responding to the usual line of treatment. And the most important thing that we consider is the mucosa of the middle ear. If it is hypertrophied, polypoidal, we'll open up the mastoid. We will allow a mastoid airspace to occur for ventilation. So these are the cases we open up the mastoid. But the other three indications, we do not open up the mastoids. Again, atelectatic
it's a more practical approach that whenever you are suspecting that there would be a disease reservoir in the mastoid, go ahead and take care of that disease reservoir and proceed for the repair of the drum or do ossiculoplasty or whatever is required. This is more practical approach. And thank you. We'll go to the hearing loss. So is hearing loss gives you any indication that you will go ahead with certain procedures during tympanoplasty?
Yes, sir. The higher the hearing loss in a normal, if you have a small central perforation with a large gap, then we must pre-operatively think that there may be some kind of ossicular discontinuity or even ossicular fixation. So that's how we should prepare ourselves while we are into the surgery, so that we can look into the ossicular chain properly and thoroughly examine the ossicular chain, because there may be bands which may look like the connection, but then this just might be bands which don't connect the ossicles properly. So this the hearing, the PTA before a surgery is extremely important.
Now the situation is, the loss is as it is said. Suppose here it is said more than 30 decibel. I'll say if it is less than 30 decibel or 30 decibel, will you go ahead and remove a facial overhang to see the incudostapedial joint?
No, because there is another thing which we can easily do in our daily cases without removing the facial overhang, is that if we have a very low hearing loss, then we are thinking that the ossicular chain is intact. So we just touch the, we just lift up the malleus little bit and look at the round window, and we just see the reflection.
And you will confirm the ossicular
that will
mobility.
confirm, yes.
So the one of the way you follow. So if it is not visible, round window reflex is not visible, then you will do some drilling, otherwise not. Okay. We will go to the size of the perforation. Now, as it is said, does the size of the perforation gives any indication? Dr. Ranjan Nath?
Yes, sir. If the perforation is very large size, like subtotal or near total perforation, then mostly blunting of grafts occur in the anterior superior quadrant. And in that situation, I usually go for a interlay technique with 360-degree flap.
Complete cuff elevation.
And if the pro-tympanum space is less, then also there is chances of anterior blunting. So in those cases, my approach is mainly interlay with 360-degree flap elevation.
Now look at these perforations.
Actually, yes.
So anybody spontaneously would in maybe figure 1, figure 2. Figure 1 is about disease in pars tensa. Figure 2 is about also some disease process in pars flaccida.
Figure 1, it is look like a mucosal disease.
Yeah.
And figure 2, it is squamosal disease.
Squamous disease.
Inactive squamosal disease with mostly grade 2 or grade 3 retraction pockets. So in the figure 2, we have to open the mastoid and see all the disease and extension, along with reconstruction of posterior superior canal wall.
Everybody of us will go for trimming of the edges or freshening the edges, or does anybody differ from my opinion?
So which one, the mucosal one?
Mucosal one. For figure 1.
The first one looks a pretty bigger size of pars tensa defect. So definitely I think the middle mucosa is also a little bit of hypertrophic and edematous. So we'll go for tympanoplasty with I think a cortical mesorectomy in this case, and underlay tympanic membrane grafting.
But we draw the margin actually here.
The margins definitely, during the procedure we will have to freshen up the margins.
Freshen up the margin.
And do an underlay technique.
Yes.
I prefer to do an underlay technique.
Yeah.
Correct.
Sir, if we, the first picture, if it is an untreated ear, then it's okay, we can go for underlay, like normal trimming of the edges and all. But if this is the picture after taking lots and lots of medicines, and this is something which is recurrent, then we might have to go for a total annular excision in this case.
So
Because
he will think of a total annular excision.
Yes, because there is mucosalization. It looks like there may be mucosalization of the tympanic membrane which is left behind.
Right. So there are changes which suggest that the granulation tissue is there, and that granulation tissue is giving a little recurrent discharge, and he is of the opinion that he will think of total annular excision. How long you will wait, and before that what what extent you give the treatment? Means local drops or local douching or what you give exactly?
We can go for normal betadine cleansing and all this thing, like suction clearance and all.
Yes.
And then we'll give them a long period of antibiotics and maybe even steroids.
Yeah.
And if there is no change in the TM
uh,
after the
condition,
treatment,
yes.
then only we'll think about total annular excision, because total annular excision hardly in among 50 cases 1 case comes up of
Yes.
total annular excision.
Yes.
It's not very common. I just mentioned because the TM look like that.
Point is well taken up. We'll move further and we'll think about what are the preferred graft materials. We'll start from that end and we'll come in this direction anti-clockwise. Sir.
Sir, I generally prefer this temporalis fascia grafting only.
Yeah.
In all the cases we are doing temporalis fascia grafting, and for cartilage we are using, if there is any cartilage reconstruction is required for the ossicle, we are using this tragal cartilage.
Anybody has any different material of first preference other than temporalis fascia?
If it is an endoscopic one,
Yeah.
a tragal pericondium may be tried without giving incision.
Pericontium, tragal pericontium, yes. If, now another question, because we have a shortage of time, what is the preference of the cartilage, whether it is a conchal or whether it is a tragal cartilage?
Tragal cartilage, I
Tragal.
generally prefer tragal cartilage.
Tragal cartilage.
Because it is easier to give the shape. The
Anybody has a experience of using PRP? Platelet rich plasma.
I have no experience, but actually I have heard in Guwahati Medical College, I think your department has done some good. Kalpana Sharma, Kumkum can tell. Doing after the graft or before the graft, a PRP is given, I don't know, but after the graft.
Yeah, that's still in practice, but since results are not being evaluated, so I'm not speaking here. So they just.
I would like to ask, I'll go to one question back and I'll go to the audience. And does anybody has any preference on any other material, that is material other than the temporalis fascia as a routine graft material? If anybody, please raise your hand. And you use what material? Perichondrium routinely as a first preference. Yeah. See, if the perforation is small, she will prefer to use. Is any added advantage of a perichondrium? Because then there must be something behind it. What is your thought process? Anything why you prefer perichondrium?
Hey, microphone.
Can anybody give the mic? From the tragal region only?
Yes,
you
yes.
are able.
From the tragal region, again we can get the perichondrium.
So it regrows.
Yes.
You mean to say?
Cosmetically, if the patient wants also, we can try for that.
Cosmetically also, the tragal perichondrium is a better material.
Better.
I'll share experience where I work. I work in Maharashtra, and most of the female patients, they will have this tragal perichondrium pierced in the middle. So I lose that chance of using the tragal perichondrium, because then I will get a very small piece. Because in the middle, somebody has a pierced perichondrium, there is some skin which is grown inside. I cannot use that material, and so I lose that chance. But otherwise, the idea behind is, this is something new learning for me also, that you can get again after a few years and perichondrium there which regrows, and yeah, that is what we can reuse it. This is a good idea.
As you mentioned one fair.
Yeah.
Actually, used to do job in a government hospital.
Yeah.
There are many injury cases come. Some perforations are big. They use the globular fat. The results are not bad. Good.
Anybody is of the
globular fats we are using for perforations which are smaller than 4 mm size.
Yes.
Smaller than 4 mm, so we can just draw the margins, and the fat has to be put in a dumbbell shaped.
dumbbells have it.
Dumbbells.
Part of has to be above, part of has to be below the remnant of the membrane. That's in practice.
Anybody has any different thing to say on the materials to be used? For the audience, this is a question to the audience. Any other material than this, what is written on the slide? Anybody has used? See, I have used periosteum when there is nothing left. Means many when there is nothing left, and I have used a periosteum, layer of periosteum, but that is very rare. We'll proceed and we'll think and we'll ask the panelist, Nebarun Dasgupta, do you prefer cartilage?
I have not done it.
You are not from.
Yes.
So any time you don't use any cartilage. Dr. Mukherjee?
I am regularly doing, sir.
Yeah, regular.
I do use composite graft in the sense that I use the tracheal perigondium,
Yeah.
the same the cartilage also.
Oh.
And part of the cartilage, rest I put it back and
Oh.
stitch it up.
Yeah.
So thing is that I get very good results. And
Yeah.
I do in a palisade pattern.
Yeah.
One after another, put it in the underlay pattern from
Yeah.
one annulus to another annulus parallelly, and after that we put in the perigondium.
Anybody uses cartilage and in the like a butterfly, or like making a slit in the middle and then putting it? Anybody is doing it?
Sir, I use cartilage only for ossiculoplasty, not for
Not
tympanic.
acha, okay, for ossiculoplasty.
Excuse me, sir.
Yeah. 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 As a tympanic membrane, as a material for grafting. Yes. I personally feel cartilage is very thick material, and whether this tympanic membrane will vibrate it or not, and that is what my personal feeling is. But
Sir, there is a cartilage slicer is there.
Yeah.
And the thickness of the cartilage is not less than, I think, 0.16 or something like that.
Yeah.
It's very thin.
Yeah.
We take a 3-inch slice of cartilage and put it in such a way that it vibrates nicely.
Anybody uses cartilage in the shape of palisade?
Cartilage slicer is very costly also.
Yeah.
And moreover, I have not seen here used in Guwahati.
Yeah, actually we have, sir.
But every scalpel, sharp scalpel, you can make a size less.
We have cartilage slicer and we have put it there, but the problem we have found is doing a post-operative tympanometry. So post-operative, when we go for a tympanometry, that is the time when you have, because of the high impedance, as sir has said that it will vibrate, but
I don't believe. I don't believe.
Anybody has any preference over the material? Conchal cartilage, septal?
I am doing it as an office-based procedure.
Oh.
I don't admit the patient even.
Oh.
I just do it, observe for 2 hours,
Yeah.
and then after that, if everything is okay, ask the patient to
Do the patient pay?
No, locally we do it. They have to pay.
Excuse me, sir.
So, because you might not be giving the complete bandage also, or you are giving bandage, not giving bandage. Yeah. Okay.
Excuse me, sir.
Some other opinion?
Yeah, sir. I am using tracheal cartilage for last 3 to 4 years,
Yeah.
though I have not published the paper yet. I have seen good result. All the cartilage they have applied very thin cartilage.
Sorry for interruption. This is
Yes,
for
sir.
ossiculoplasty or for the...
For myringoplasty, sir.
Myringoplasty.
Yes,
Oh.
sir. Yes, sir. Myringoplasty type 1.
Yeah.
So the result what I have seen till now, or I am following it with a audiogram also,
Yeah.
I find it very good. Almost 14 cases I have done till now,
Yeah.
and they are giving, every patient is fine till now. So I will follow for a few more months and then I will publish it.
Thank you for sharing your views.
Thank you, sir.
So anybody does endoscopic exclusive tympanoplasty? Exclusively endoscopic in our panelist?
No, sir, I am
Exclusively.
microscopic guy.
So we recently had a talk on
I do
endoscopy.
endoscopically, sir.
Only endoscopically?
Only endoscopically.
So you don't have microscope in your...
No, I have got.
So the problem
But I
is...
prefer to use endoscope.
Yeah.
So the problem of using only endoscope is when we get a very narrow external artery canal.
Yeah.
So
Yes.
cases...
In a smaller canal, it becomes very
so if it's
difficult.
very
So-
narrow, then definitely you have to switch over to post.
So whosoever is adapted to a particular type of technique, like somebody is very familiar with the microscopy, you cannot switch to the endoscope.
Both are excellent tools and both actually help each other.
Yeah. Anybody has come across that tried for few cases endoscopically and given up doing endoscopically for certain reason?
Sir, I have tried few cases 1 to 2 years back.
Yeah.
And I got difficulty in placing the graph.
Yeah.
Because it is a one-handed technique.
It's a one-handed technique, yeah. So you have some other view to say?
With the microscope, nowadays I use weight graph.
So
or
the
phase graph.
question to the audience, anybody has to tell about the exclusively that endoscope is far better than microscope, or anybody using routinely?
Anupam can do,
I think I think we had one talk and we had seen the advantages.
Sir, I am doing a microscopic surgery for the last 10 years. I don't feel any need of endoscope while doing a myringoplasty or
Right.
mastoid.
Those who are used to microscope, they are continuing with the microscope. They have tried few cases with endoscope, but because of the problems single-handedly and they come across some difficulties, they have given up doing it. But any new technique comes, we feel that we should try it and we give a fair trial, but then you come to back to square, and because there are some shortcomings in that particular procedure. So let us move further about pediatrics. Let us skip this pediatric slide. Now let us discuss that there is a grade 2 retraction pocket. Malleus is present, incus is absent, stapes is present. This is a usual situation, and 40 dB loss. Now let us ask the panelists, what will be your take? Whether you will go for the cortical mastectomy, inside out, outside in, anybody?
This is a case for doing it inside out.
Inside out, right.
Yes, and first I would just like to mention is that if the patient has not come regarding the hearing loss, sometimes you don't even have to operate.
Yeah.
Because if you operate in this kind of, if it's not 40 decibel hearing loss.
Yeah.
If I have recently encountered few patients who have like only 20 decibel
20
hearing
decibel.
loss, because they are hearing well directly through the tympanic membrane attached to the stapes.
Stapes.
And if we can see the pocket,
yeah,
the base of the pocket,
yes,
and then it is better to leave it that way.
It's a shallow retraction pocket,
yes,
not a deep retraction pocket.
Yes, and it's better to leave it that way. If the because sometimes you may not be able to give that much of a hearing.
Yes, you may not, patient may not be benefited hearing wise,
Yes,
even if you
yes.
do the surgery. And if you can see the retraction pocket with the endoscope and or microscope, there is no point in doing that. Anybody differs with him?
So actually the whole concept of doing cholesteatoma surgery, I think is very individualistic.
Yeah.
But I'll keep things very simple. What we follow is, when we open up the mastoid antrum,
yeah,
after that we take the decision.
Yeah.
If we get an intact sac, which is limited only to middle layer, atic and mastoid, we will go for a canal wall up mastoidectomy.
Yeah.
If the cholesteatoma is invasive, is going beyond the mastoid antrum, entering to other air cell spaces,
Yeah.
then those are the cases with a sclerotic mastoid, we
Yeah.
will do a canal wall down.
Down.
This case have a grade 2 atic retraction pocket. I think it is an intact sac.
Yeah.
And with M plus, malleus and stapes superstructure is present. Now in this case, we will like to do a modified intact canal wall mastoidectomy. Why I tell you modified? Because the older intact canal wall mastoidectomy use a facial recess approach to enter into the sinus tympani, do a large EP tympanotomy. We do not follow this nowadays. Transmeatal will do an aticotomy.
Yes.
We'll just drill the outer atic wall to a level that we can actually see the tegmen plate,
Yeah.
and we can work on the anterior atic space.
Do you reconstruct this lateral aortic wall?
Yeah, definitely. That outer aortic wall has to be reconstructed with a conchal cartilage.
Yes.
And we will just drill the posterior bony rim up to the level of the pyramidalis process.
Yes.
So that we can see the sinus tympana area, and we will also see the posterior tympanic sinus. We'll clear from that, and we'll also reconstruct that with a fibroperiosteal tissue. Regarding the ossiculoplasty, this definitely which step is superstructure. We can either go for a transposition or an ossiculoplasty, but I would go for a columellar technique and do a myringostapediopexy.
Yeah.
That's we can do.
This is in short.
So we'll do a
about,
modified intact canal wall mastectomy.
This is about a canal wall up. Let us go to case number 2, where there is a frank epithelial flakes and cholesteatoma in the aortic, antrum, and mesotympanum. All ossicles are eroded, including superstructure of the stapes, and with moderate mixed loss. This is our last question. Now, what will be your approach? Canal wall down or canal wall up?
This one will definitely go for canal wall down.
Down. Anybody differs? Any panelist differs from the canal wall down approach?
Sir, I will definitely try for a canal wall up in all the cases. If I cannot clear the disease entirely, then only I will go for the canal wall down.
Intact canal wall.
Intact
on
canal
both
wall,
sides.
yes, sir.
So,
Yes, sir.
open the mastoid posteriorly and do some inlay or some lateral dichotomy,
Yes,
and then close that defect.
Yes.
So, anybody from the audience differs or wants to add anything, because this is going to be the last question. I would like to ask my last question because there are many more questions. Will you ask all the patients of the suspected cholesteatoma for HRCT temporal bone?
No, sir. Only if if I suspect there is any complication there, then only I go for it.
Ask for the HRCT. Anybody differs?
For me, sir, it is yes.
Yes.
If it is a suspected.
What additional
squamous
information you
disease-
get? What additional information?
Additional information, sir, we get the status of the ossicular chain, level of sinus plate, dural plate, and erosion of lateral semicircular canal or not. And this sort of additional information. we
Anybody has to add anything?
Sir, I will say yes, because actually by looking at the extent of disease, we can plan the surgery.
Yeah.
So we'll know about a low-lying dura, forward-lying sinus, as you said,
mentally prepared.
Yes.
or in facial canal dehiscence.
Yes.
So for me, actually, yes, if we have the luxury, then why not use it?
Even any complication.
So initially, any new technology comes, it little costlier also and little problem of affordability. So we try to avoid, but as we come to know about the extended applications of any technology like HRCT temporal bone, and which is likely to give more information, you tend to do that investigation in more and more number of the patients. And then like before nasal polypectomy, before CT scans, still we used to operate nasal polyposis, but now it's operating on the bilateral ethmoidal polyposis without CTPNS is something which is not done.
Yeah. But sir, for a recurrent case or previously done surgery, I would go for a diffusion weighted image MRI, because that is the modality.
It helps in the sir for medical legal purpose also, and to counsel the patient. That what operation I'll do. At least we can talk with the patient and the party. If you do the HRCT pre-op.
Yes, yes. So on this question of HRCT temporal bone, I thank you all the panelists, and I thank you the audience for patient listening. We are at the end of our tympanomastoidectomy panel discussion. I thank you the organizing committee for giving me the opportunity to moderate this session. The session of tympanomastoidectomy is like a continued medical education. We will go on in different conferences throughout the nation, and we will continue the same discussion in some other place. Thank you so much.
I would now like to request the moderator and the panelists to kindly come forward to the felicitation corner. I would like to request Dr. A.K. Bhattacharjee and Dr. P.M. Bora to kindly felicitate them. we have an announcement. We have installed equipments to test vestibular function like VNG, stabilometry, ECOG-G. Anyone interested can visit the stall after the orations are over. The equipments available are VNG, stabilometry, craniocorpography. The stall is near Hall 2. Now we have the presidential oration. The chairpersons are Professor Dr. A.K. Bhattacharjee, Dr. H.P. Saikia, and Dr. B.N. Sharma. The speaker is Professor Dr. Anjali Borua.
laptop. ये ले जाओ, इसका ऊपर रखेगा, प्रॉब्लम नहीं होगा, ये चार्जर लगा दो, ये चार्जर है धीरे धीरे हाँ I just don't be very
Good evening all. Now is the presidential speech by our present president, Dr. Anjali Borua. She is a very dynamic lady with a very colorful, very successful career in her life. She was a champion of badminton and tennis and everything. And now we are presenting Dr. Anjali Borua for the presidential oration.
Good morning to the esteemed audience. Honorable Chief Guest, Padma Shri awardee Dr. Ravi Kannan, President-elect Nebaoicon 2023-2024, Professor Dr. Biraj Das, Honorary Secretary Nebaoicon 2023-24, Professor Dr. Nicholas A. Lindo, Honorary Organizing Chairperson, Nebaoicon 2024, Dr. Tapas Das, Honorary Organizing Secretary, Nebaoicon 24, Dr. Anjana Sharma, renowned neurologist, Dr. Seriwa Darisala Sir, Dr. Amitabh Roy Chaudhary, he hasn't come probably because of the weather condition elsewhere in our country, Dr. Anand Dr. Sir, Professor A.K. Bhattacharjee, Professor Pradul Hazarika Sir, Pradul Hazarika Sir, Dr. A.P. Dr. Sir, Honorary Treasurer Nebaoicon 2023-24, Dr. Nitesh Sir, Moirang Tham, and all the learned dignitaries present in the auditorium, all my fellow friends, well-wishers, young ENT consultants, and PG students. So before going to my presentation, I am indebted to all the members of Nebaoicon for choosing me as a president and giving me a chance to serve you. Here I am uploading some few beautiful photographs and of flowers and plants from my tiny garden. Those I reared since when I was very young, as they give me happiness and pleasure. These are the photographs, and few other photographs are also there. Then this is a yellow nerium. Then these are adenium flowers. Then this is kalanchoe and hibiscus. This is white hibiscus and petunia. Now about these are the photographs when I was in school. Played for Assam and Meghalaya at the time in table tennis and nationals, and this is the story of my bygone days. Life starts here. We left sports. I left sports and joined medicine to start a new career. Since my young age, I developed a fascination for flowers and passion for table tennis. Though I am still associated with my passion, it took a back seat after I enrolled myself as a medical student. But my fascination with flowers continued. However busy I was, I just took time to be with my flowers. This indulgence with flowers soothes my mind and motivates me to take the responsibility in whatever I do, or more importantly, in my medical profession. Some of the photographs with my patients who came back to me after 40 years. This is a really very important event in my life. I was a lung cancer survivor also, rather winner. The renowned robotic surgeon, Professor Dr. Arvind Kumar, who gave me my life back. I joined hands with him to fight against air pollution, and he has made me Doctors for Clean Air champ for Northeast. Another picture, this is from Rodalie. I have received some felicitation. So what I have accomplished, not only giving care, but it is also healing and serving with, I have learned to help others. So this is my name. This is Nemka Hospital where I am working at Bhangagar right now since 2007 after taking VRS from State Medical Service. You give the pictures. These are the flowers I have already told. Not only this one, my hospital. I am working. So next slide. Falls. Next slide, please. This falls and its prevention in elderly now begins. My actual presentation begins now. As I am also a doctor, my mind focuses more on sufferings of elderly people, and they are the most vulnerable in the section of society. They are unable to protect themselves. They suffer from health problems, high levels of stress, mental illness, infection, economically, socially, and environmentally also. They are vulnerable, and falls are very common in them. So my presentation is on falls and its prevention in elderly. Next slide. So these are the people, even they are holding their sticks, they are about to fall. These are elderly people. Next slide. So introduction, just I would like to tell you that injuries to fall are life-threatening sometimes and may even cause death. Next. So if you say the definition, you want to say what is the definition of falls? It's an event in which a person comes to raise accidentally or unwittingly on the ground or an uneven surface at a lower level or on floor. Next slide. So every day about 27,000 older adults above 74 years, and they are die due to fall. And there is chance of fall in every 1 in 4 older adults. More than 70 million require medical attention or remain in home with restricted activity. Next slide. Every second, every day, one fall, and falls are one cause of hip fracture. The incidence of getting falls becoming more and more, and it will be almost double in 2030 what it was in 2014. So there are some risk factors with falls. These risk factors are causing falls may be due to musculoskeletal dysfunctions, maybe due to visual disturbances or neurological problems or diseases the patient is suffering. It is found that females are more sufferer. Why? I don't know, because they are not that, I mean, not like balanced like, yes, not like balanced like the male, their male counterparts. So there are some modifiable causes which we can treat, like the metabolic causes, diabetes, cardiac causes, then calcium deficiency, diesel calcium deficiency, weakness on the body and muscle, musculoskeletal problems like balance and gait problem, foot problem, and these are the modifiable causes. Also the vertigo, peripheral neuropathy, Parkinsonism, movement disorders, psychological causes like depression, fear of falling, sensory impairment, visual and auditory, illnesses, anemia, infection, nocturia, incontinence. They are all modifiable causes. Then drugs overdose, we are very important. Then there are some people, they are taking multiple drugs, so we have to be very careful so that they don't become a victim of fall. Then non-modifiable causes are there. Non-modifiable causes are what? What are the non-modifiable causes? Next. Non-modifiable causes are the elderly people who are more than 80 years of age, then with cognitive impairment, dementia, those patients with TIA, then where there is history of falling, is there. Recently elderly patient, if discharged from the hospital within 1 month, then also they are the victims of falls. Then white races, they have more tendency to fall. Next slide. So we have to remember that one thing, I hate falling. You will remember the causes of fall, inflammation, hypotension, like that. A long list of this you can remember, easily you can remember. Next. So medication, there's a long list of medication, hypertensive medication, then there are depression, and for depression also we use lots of medications. So this should be properly looked into, and there is every chance of missing a dose also. So overdosing also may be there. So there is a long, I don't go into details, so you have to be very careful when you are using multiple drugs especially. Then there are some, now next slide. This slide actually showing the causes of fall, including some environmental factors. These environmental factors are on the below down. That is, if the floors are not good, stairs are not properly arranged, or they're not properly constructed in a house. If there is poor lighting also, then if the person is walking frames are not that proper, these are the causes apart from other causes which are mentioned above. And their effects of fall are there. They are also on the right hand side. I have given the effects of fall. These are lack of activities. Patient due to fall, there will be lack of activities. The elderly will not be able to move from home. Psychologically also they will suffer from anxiety, depression, and there will be loss of confidence also. Next. Then assess, how do you do the assessment fall, effects on this, next slide. Not coming? Next slide. The assessment of fall. Assessment of fall may be from skin injury to fracture of bones and head injury. Maybe that psychologically the person becomes more dependent for fear of falling. Next. Then already we have discussed the presence of associated symptoms. Then about the, now I'd like to tell a physical examination should be done, including vital signs. Then we have to look for orthostatic hypotension. Then postural changes also look into. The eyes and ear examination should be done. Then hydration status is also very important. Then systemic examination should be done. All systems are including the vibration senses. Presence of the agopisod. Next. Physical examination I have already told. Then this systemic examination Agorkhon. I have already told about systemic examination. Then explain that all systems should be examined. Then environmental next, the environmental assessment. Environmental assessment I have already explained. Then next slide. Testing and imaging should be done. This should be next slide. This relevant testing, including where it is needed, CT scan or MRI should be done. Next slide. American, next slide. This is not this one, the previous one. Previous. Good, Gusa. Taragorkhon. This American Geriatric Society and British Geriatric Society recommend that, what they have recommended, that all adults who are above 65 years of age, they should be screened annually for a history of fall and balance disorders. Next. So, these are for care of elderly. We should follow the dictum of steady, stopping elderly accidents and deaths and injury. Just this dictum should, everyone should know. Then, next slide. Older, Okay, just we have to use, just I'll make it very short. How many times left? We have to, 1 minute. We have to use scores. Scores are very important. 0 score to 1, 2, 4, 1, 2, 3, 4. We have to ask some questions. So this question should be, and if the scoring is more than 4, then it is, there is every chance that the person will fall definitely. So when worried about fall, to stand up if a patient needs support, it is a major sign of weakness and in leg muscles. Next. Then, and this measuring the ribs. So already there are so many slides. This up to next slide. These are tests now. Next slide. Only 3 and 4. This special test or optional test, we can do tuck test. Then another test is the optional test, 30 seconds chair stand. There is another test that should be done. And at last, I'd like to say that in a step-by-step wise, we can do multifactorial risk assessment should be done. Then only we can prevent fall. And so intervention should be multifactorial. Rehabilitation should be done not only physically, socially, and psychologically. That is very important. The summary, this I have For elderly ages 65 or above, the responsibility falls on healthcare providers for identification of being of fall assessment and intervention from all sides of the elderly aged 65 or above. These are the references. And I have not seen the references. Didia, Tolole Didia. Tolole Didia, how dia? Hekon, these are tests are optional tests. So, last slide. Econopa Dijo, these are 4-stage balance tests. So, multifactorial intervention should be done. And this is rehabilitation, I have told, physically, social, and psychological then of the person. These are the different appliances used. Physiotherapy is also taking active parts in the, to prevent fall also. Next. So I have told this about elderly patient about 65, they should be properly take care and from all sides to prevent fall. And next slide. So references, next slide. So if you are born with the weaknesses to fall, you are born with the strength to rise. Next, thank you very much for your patience hearing. I have probably not making you myself. It's a different subject, no? So everyone should know. And I have become also elderly doctor now. I also myself take care of, not only myself, my colleagues are there, also there. So many doctors are there, sir. They should know about how to prevent falls. That's why I am taking not from ENT, but how to prevent fall for all of for the benefit for all of us. That's why I have taken this subject, sir. Yeah. Newborn baby, maybe newborn baby. People are there for look after the newborn babies, and the orthopedics surgeons are there. For old persons are mostly neglected. Even neglected by their parents, what we have seen in so many newspapers. Yeah?
Hello. Madam, you may have aged, but you are not elderly.
Okay, thank you so much.
You are the most
But for me, even then I have to tell frankly that this time I will be 70. So I'm, 70, this is my number only. And I'm physically fit, so that's why I'm doing all sorts of work and very busy in my work. Thank you so much.
Thank you very much.
Thank you, ma'am. I would like to request Speaker ma'am to kindly come forward to the felicitation corner. I would request Dr. Pradul Hazarika to kindly do the felicitation. I would like to request the chairpersons to kindly come forward to the felicitation corner. I'd like to request Dr. Bhaben Chaudhary to kindly do the felicitation. We'll have a short tea break of about 5 minutes before the inauguration ceremony.
We have a small announcement to make. Dr. Anjan Jyoti Bhuiya sir has dropped his coupon and with the iCard. Please collect it from the organizing committee if you can hear me. Thank you. Good evening, everyone. Ladies and gentlemen, now we are going to start our inaugural ceremony of 35th Nebaoicon. I would like to request Dr. Rinku Ghosh Rehman to kindly escort our dignitaries. First, let's welcome on stage President Neboy, Professor Dr. Anjali Borua. Next, let's welcome on stage our chief guest for today, Padma Shri awardee Dr. Ravi Kannan. Please give a big round of applause. Please have a seat. Next, let's welcome on stage President-elect Neboy, Professor Dr. Biraj Kumar Das. Let's welcome Honorary Secretary Neboy, Professor Dr. Nicola C. Lingdo. Next, please welcome on stage the organizing chairperson, Nebaoicon 2024, Dr. Tapos Kumar Das. Last but not the least, the very special, please welcome on stage the organizing secretary, Nebaoicon 2024, Dr. Anjana Sarma. Now, I would like to request IMA President Dr. Dilip Borua and Neboy Joint Secretary Dr. Sabita Neok to please come on stage and felicitate our dignitaries with Phulon Gamusa and bouquet. Please welcome on stage, ma'am. Please welcome on stage, sir. Please give a big round of applause. Please welcome on stage Dr. Fozia Shireen Hakim to felicitate our dignitaries. Please come over the stage, ma'am. Now, may I request Dr. Fozia Shireen Hakim to kindly felicitate Professor Dr. Biraj Kumar Das. May I request Dr. Fozia Shireen Hakim to kindly felicitate Dr. Nicola C. Lingdo. Next, may I request Dr. Mohua Bora to kindly felicitate Dr. Tapos Kumar Das. may I please call upon stage Dr. Malabika Borua to kindly felicitate Dr. Anjana Sarma. Now we shall begin the ceremony by playing our Zatiyo Hongit, Omur Apunar Dekh. I would like to request everybody to kindly stand up for our Zatiyo Hongit. I would like to request the technicians to kindly play the song. Thank you, everyone. Now, I would like to request our dignitaries to kindly proceed towards lighting of the lamp of wisdom.
শব্দ ব্রহ্ম রূপে তুমি ওঙ্কার রূপিণী সৃষ্টির আদিতে তুমি শব্দ স্বরূপিণী ওঙ্কার ধ্বনিতে তুমি
I will now want to request Organizing President Nebaoicon 2024, Dr. Tapas Kumar Das, to kindly give the welcome address.
Good evening, esteemed chief guest of today's function, Padma Shri awardee and a winner of Raman Magsaysay Award, the very well-known Dr. Ravi Kannan sir. President, NEBUI, Dr. Mrs. Anjali Borua ma'am, Secretary, Dr. Nicholas Ilindo, incoming President, Professor Dr. Biraj Das, my Secretary of Nebaoicon 2024 Sipsagar, Dr. Anjana Sharma, the esteemed dignitaries in the audience, which includes the renowned speakers from different parts of India, whom we have invited here as a resource person, the Lifetime Achievement Awardees, the sports persons and doctors, the winner of the sports awards this year, my teachers in the audience, my colleagues, friends, and their families, ladies and gentlemen. I take the proud privilege to welcome all of you to Nebaoicon 2024. It's a huge moment, let me tell you. It's a huge and thrilling moment, not only for me, not only for the doctors, ENT doctors of Sipsagar, but for the entire doctor community of Sipsagar, that we are here to organize, to host Nebaoicon, the Northeast Annual Conference of the Association of Otolaryngologists of India. My secretary, Dr. Anjana, while making the agenda, she has put a big restriction on me. I've been allotted very little time. And well, frankly, I'm happy also because I'm so tired. As you can see, since morning I've been running around. I don't have anything. I even didn't have time to prepare my speech also. So let me just let my heart out. Today, let me talk about my dream, a dream which the ENT doctors have dared. It's the story of a few dreamers and a story of a dream. The dreamers, of course, are the ENT doctors of Sipsagar, and dream is Nebaoicon 2024. The dream started when this conference was allotted to Sipsagar to host this Nebaoicon 2024. Well, it seemed like a distant dream, frankly, because Sipsagar, as you have seen, is a very small town with so little infrastructure. What we have, we don't have an auditorium. This auditorium, this state-of-art facility, which you can see where we are sitting here, it belongs to ONGC. And they are very kind enough to lend this auditorium to us to host this conference. We don't have manpower. Our ENT fraternity is critically small, very small. And the doctors which we have, statistically speaking, 70% of the doctors are above 65 years. And when you talk about a fund, for a small population of ENT doctors in Sipsagar, it's very difficult to raise fund. So all these, things really, it was very frustrating, and we thought it may be a very distant dream. We never thought this will materialize. Initially, we were very apprehensive. We were very hesitant, but we dared to dream. And in this dream, of course, a lot of people helped us. For example, the doctor fraternity of, non-ENT doctor fraternity of Sipsagar, they have all come and helped us since so many times. This is sort of, sir, Kannan sir, for Sipsagar, this is like a tradition. It's a legacy of sort, where any conference of any discipline, all the doctors of Sipsagar come together and we work as a team. And this time it was no different. There you can see a lot of IMA members, they are sitting here in the audience. Since morning they have been working. You do not know them, but they know you. You may not have seen them, but they are in your radar. They know you. So because of these people, this dream probably was possible for me. Then I should thank another group of individuals who, of course, they are from the pharma industry. Pharma industry, definitely, I must thank them because, I mean, if they didn't help us financially, probably this kind of conference is never possible. But let me particularly speak about some young boys who are working with us since last almost about 4 weeks, just like shadows. So we call them the friend of Nebaoicon. These people are so helpful, and in every department, they've taken charge. Call it food, venue, transport, accommodation, everywhere, these people are helping us. So after, at the end of almost 75% of the first day, I don't know what is your verdict. I'll not ask you your verdict because your verdict might disappoint me. So I don't want to be disappointed. But I do feel the dream which we dared few months back seems to be a reality to me. We have one more day of the conference left tomorrow. I hope all of you will enjoy our hospitality. You'll enjoy the academics, our food, our brotherhood, our fellowship. If you find any flaws, please forgive us. And if you have any suggestion, you want to have any help from any of us, please don't hesitate. We are trying our best. The dream, really, we had lot of obstacle in realizing this dream. Probably Kanan sir can tell you how difficult it was to get him up to Sibsagar. The way I navigated him from Silchar to Sibsagar, if you hear it, it's a very long story, probably he can only tell you. Anyway, thank you so much. Thanks for being at Sibsagar. Thanks for being a part of Nebaoicon. Long live NEBAI. Long live Nebaoicon. Long live Sibsagar Academy of ENT Surgeons. Long live IMA. Thank you very much.
Thank you, sir. Now, I would like to request President Nebaoy, Professor Dr. Anjali Borua, to kindly grace us with a few words.
Namaskar. A hearty welcome to Chief Guest, Padma Shri awardee Dr. Ravi Kannan, President-elect of Nebaoicon, Professor Dr. Viraj Das, Honorary Secretary of Nebaoicon, Professor Dr. Nicola C. Lindo, Organizing Chairperson, Nebaoicon 2024, Dr. Tapas Das, Organizing Secretary, Dr. Anjana Sharma, 2024, and all the honorable personages present here, youngsters of ENT fraternity, honorable associate colleagues of Nebaoicon, our executive colleagues of Nebaoicon, and all the members of the organizing committee. I don't want to fail to utter the names of Dr. A.P. Datta sir, Dr. Naren Datta sir, Dr. Prabal Hazarike sir, Dr. Bhaven Chaudhary, Dr. Kudus Ahmed, Dr. S.B. Khan, Dr. Pranab Borua, and Bhattacharya sir, and all who are present here. Again, I am uttering a very good afternoon. It is a pleasure to meet you and offer my heartiest thanks. As I stand here, I remember taking over my chair's responsibility as the president of Nebaoicon in the year 2023. I am grateful to the former president of Nebaoicon, Dr. Priyasakhi Devi, from whom I took over charge, and my journey as president of Nebaoicon would not have been possible without the active help and cooperation of the members of Nebaoicon and participation of doctors, friends, and colleagues. My mission was to create a dream team of Nebaoicon, where everyone of each state of Nebaoicon would play with their strength and their tangible steps to bring our organization to a new height at national level. I want to emphasize that during my tenure, I motivated all the neighboring states and Assam to organize workshops, CMEs of their own, and under the umbrella of Nebaoicon to create an environment conducive of learning and spread knowledge and skills. Now I would like to say that we, the ENT specialists and surgeons, are not lagging behind here. Every ENT doctors have developed their instinct to grow. And amongst us, I proudly announce that we have quite a good number of distinguished national faculties, figures here, sitting here. Lastly, I am very proud of them. Lastly, I request our newly elected president-elect to president to look into all the matters which I and we could not give a solution in spite of the best efforts to provide his helping hands and assistance for our community for a practical solution. With these few words, thank you for your time and attention. The journey of a decision, of a journey of 1,000 miles begins with a step. I mean, give a strike and to reach your goal, ultimate goal. But not the least, at the end of my lecture, I'd like to inform you that the conference and the workshop, the 2023-2024 team members organized at various places of Northeast. But we can, if you count approximately, it is around 22 CME workshop and meets, including, just I want to mention, including rhinoplasty, ablation, vertigo symposium, allergy symposium, and so many others with our own specialists and invited renowned faculties from our national arena. I'd like to, and at the end, I'd like to distribute all the information to you now, kindly through some, already I have started to distribute my printed copies of our achievements. So thank you again. Long live Nebaoicon, long live all, long live ENT surgeons. Thank you so much. This is my last day probably. I again thank you for giving you thanks. Thank you.
Thank you, ma'am. I would like to request Honorary Secretary, Nebaoicon, Professor Dr. Nicola C. Lindo, to kindly come forward and speak a few words.
Respected guest of honor, Dr. and Padma Shri, Dr. Ravi Kannan, respected President Nebaoicon, Dr. Anjali Barua. It's okay, it's working. Yes, incoming President Nebaoicon, Sir Professor Dr. Biraj Das, and the organizing President Dr. Tapas Das, Dr. Anjana Sharma, organizing Secretary of Nebaoicon 2024. On behalf of the executive body of the Northeastern branch of AOI, I would like to extend my warm welcome and to all of you to this 35th Nebaoicon 2024. We are indeed very privileged to have such a platform where we have ENT surgeons from all over the Northeast, where a place where we can meet, greet, and share our experiences, our difficulties, and our achievements at this very conference every year. It also gives us the opportunity to visit different parts of the Northeast and acquaint ourselves with rich and diverse cultures and heritage of the various Northeastern states that we so proudly are a part of. The theme of this conference, Dare to Dream, as Dr. Tapas has said, is really apt, as you can see how this small but effective, I should put that in apostrophe, small but effective organizing team has put on their best efforts to bring about a conference of this magnitude, and with the little and with the minimum resources that was available to them. And I'm really grateful to them because we have been having a troubled situation in Manipur, and I could not really be able to give my logistic support to the team, and also actually to Neboi. As you all know, we have been torn by suffering, and we are limping back into normalcy little by little every day. But we are yet to recover from the malaise that has been tormenting us for the last 18 years in our state. I was unable to coordinate, in fact, with any of the, say, with the Neboi group for quite some time. And of course, I was lucky to have a very dynamic president, Madam Anjali, who could take matters into her own hands, and she kept the working spirit of Neboi going. I deeply apologize for the inconvenience, but I would also like to thank all my seniors who I thought I would resign on moral grounds because of the inability to do anything at all. No internet for 5 months, and whitelisting of the phones was a very tedious task. But I like to take this opportunity to thank my seniors, Dr. S.B. Fukansa, Dr. Biraj, Biswajit, and then who said, no, madam, you must continue, you have to finish, Nobody has ever resigned in Neboi. So anyway, that is the thing. With the coming of the state-of-the-art facilities and the recent developments in the field of otorhinolaryngology, I hope that this conference brings out the best in each and every one of us and provide us many more opportunities to learn, especially the upcoming and the budding ENT specialists of our Northeast, who have very tirelessly worked to bring up their skills to the national level. There's so many of us now who are known, say, at the national level, and to name a few, Dr. Gautam Khan, Dr. Nitishwar, who were awarded, many awards in the national conferences. We are really proud to have them in our midst, and I hope that we will learn from them, and this interaction and an enhancing of our knowledge and skills, and with the help of their expertise, in their field, will help us to grow more progressive. And yes, with the age of digitalization, Zoom meetings and live, say, conferences and say live workshops via the internet, I hope that we can learn more. Last but not the least, I wish this 35th Nebaoicon 2024 a grand success. Long live Neboi. Thank you.
Thank you, ma'am. Now we'll have the release of souvenir and Neboi journal by Chief Guest Padma Shri awardee Dr. Ravi Kannan, who will be assisted by editor Dr. Sabita Neog and Professor Dr. Rupanjita Sangma. Let's welcome upon stage Professor Dr. Rupanjita Sangma and Dr. Sabita Neog. Please give a big round of applause.
I just want to inform you that the cover page is an art by one of our colleagues, Dr. Manisha Gogoi, who is a pathologist, who is working with our ONG hospital.
Now we will have the handing over of charge from present President Neboi, Professor Dr. Anjali Borua, to President-elect Professor Dr. Biraj Kumar Das. I would like to request the present President to kindly do the handing over ceremony.
A big congratulations to you.
Now, I would like to request our new President Neboi, Professor Dr. Biraj Kumar Das, to kindly give his welcome speech.
Sarvitra Sukhinaha Santu, Sarve Santu Niramaya. So I, on behalf of Nebaoicon, would like to thanks everybody to make it success, the 35th Nebaoicon held at Sivsagar. At the outset, I like to address my seniors, Honorable President Sir of Nebaoicon, Madam Anjali Borua, Honorary Organizing President of 35th Nebaoicon, Honorary Chief Guest, His Excellence Padma Shri Dr. Ravi Kannan, my respected teachers, especially Dr. Anand Datta Sir, Professor Arun Bhatta Sir, my senior like Dr. Gutuzda, Sambuda, Marcelda, my juniors, my students, Dr. Debajit, and so many with my boys and girls. Today I can stand boys and girls because I am an aged person here. Most of my students are becoming professors now. So I have already retired in 2021. Again I have joined as a principal of a medical college, that is P.A. Sangma International Medical College at Meghalaya. At the very outset, I would like to thank you all for giving me this opportunity to serve the association as a president, and I was always involved in this association since it started in Guwahati Medical College in 1985. So that time it was me to sing a chorus only. I had the responsibility to organize a chorus with Professor K.P. Saikia is a singer and Professor Kavita Barua is a tableist, and so many madam, means wives of Professor Vedas, Professor Dr. Anand Datta Sir and all. So we enjoyed that time in 1985 in Dental College, Guwahati. After that, while I was PG in Dibrugarh, the second conference was done, and that was recognized as a Nebaoicon in Dibrugarh, and it was totally arranged and organized by two luminaries, late Professor Anand Datta and late Professor B.R. Das. And I'm really thankful to those teachers because we had their imprint with us, and these people helped us a lot. They have molded us as a professor. Today we are being here only because of this sort of professors. We are fortunate to get it in our life. I hold the post of secretary once, treasurer once, editor of journal, chairman of editorial board. So step by step I did everything, and I came down to the stage of president today for organizing up to 36th Nebaoicon to be held at Tripura. So in my days, what was my objective that could not be filled up? Now again I have the dream to highlight my juniors, my students. While I was a secretary with a dynamic treasurer, Professor Jyotirmoy Phukan, who is in Barpeta Medical College, we had tried to do so many things, and we tried to upgrade our juniors, even starting from Gautam Khan, Jyotirmoy Phukan, S.D. Phukan, Alsina Sambhuda and all. They were involved in so many conferences and workshops, and I was last to call the faculty from other places, because what I feel, we have our potentiality to do everything. Why not we upgrade our students? So whenever and whatever I go as an external examiner for postgraduates, I used to take 2 juniors with me to organize one semi, like one Dr. Anjan Bhuya, he did thyroid in Tripura, like Miklu Senapati, he did endoscopic surgery in Manipur, and so many. So that way I did a lot, and now again that footstep, that aim should be completed with the help of my seniors, because thing is that whatever you organize, very importantly, everything should be not Google closed, it should be close to your physical touch. Because whenever we were, Dr. S.B. Phukan and me, our meeting was always in the MMC campus, MMC canteen. And we organized, and it was done very nicely. So that way we did it, and again I'm thinking the juniors to do, and they will do everything, they will show their potentiality. Very important is that there will be surgical workshop to be done by our junior faculty, and it should be dissected by panelists. We have our panelists, our senior faculty, they will criticize, moderator, they will moderate, and we have a learning from them only. Why should I have so much of the expenditure? Because we are crisis of money here. So far, Tapas Das has already mentioned. So that way I'll do. And this year, I appeal to have good cooperation with all members, and so that I can do something for upgradation of our young faculties to expose the potentialities by engaging as a working surgeon, and the senior faculties will play a major role to criticize the sufficient subjects as a panelist, as a moderate, as a chairperson and all. So senior surgeon will like to charge as a spectator in the different states. 7 sisters will have to include all equally, because whatever I thought, once upon a time it was really tough to do a conference at Tawang, where Dorji Khandu, the late chief minister, was the chief host, and we arranged the oldest person like Anandatta Sir, Professor Tibura, they went there, they enjoyed like anything. They were staying not in hotel, these are 10th house of armies. They enjoyed a lot. So and that's why I'm thinking about to do something in Arunachal Pradesh, as I have a soft corner with them because I was there for 1.5 years as a professor. So I would like to involve those people who can do lot many things. And during my period, I need to have my help from my students, my dear students, Subhamay Chakraborty, who will be the president-elect for my tenure, and I need to have so many help because I'm thinking to have my journals twice a year. We need to have indexings. That part can be completed within 1 year. Another important point, as mentioned by Biswajyoti Gogoi, is that transfer of account is nothing to do. Transfer account should be held at Guwahati only, and it can be done only Google transfer. Everything can be done very easily, so that way we'll do our office in Guwahati. and secretary and treasurer must be accessible for me, and good potentiality of editorial chairman, I should not mention, after election only it can be done, editor and chairman of the journal. In my tenure, I like to upgrade the journal as I have mentioned. So this is my aim and objective to complete as a president, Nebaoicon, to organize the 36th after 1 year. And being a principal of an institute, I may not have much time, so I'll have to decentralize everything so that vice president, I should not mention the name, will do so many things for me, because I'm not that ambulant to work these things. So thank you again. Thank you very much. Thank you everybody. Long live Nebaoicon. Thank you.
Thank you, sir, for your welcome speech. Now, may I request our chief guest, Padma Shri awardee, Dr. Ravi Kannan, to kindly come forward and grace us with a few words.
Ladies and gentlemen, it is such a pleasure to be here amongst so many friends. I actually did not realize that there are so many colleagues here, so many people who I regard as close friends, relationships built over the last so many years. Thank you, Dr. Tapas, for inviting me to participate today. And Dr. Tapas was mentioning how together they organized this conference. He had his doubts about hospitality, and I don't think you need to have any doubts. The way things are being organized here, it's a big organization. I didn't realize there were so many, 350 odd delegates, but it still feels like a very closely knit organization, very closely bonded community. And thank you very much for inviting me. I hope you have a good conference, good learning experience. Thank you very much.
Thank you so much, sir, for your kind words.
I'd like to add just one more thing. He mentioned, see, today medicine, healthcare is truly interdisciplinary. And he mentioned how all the different specialties in Shiv Sagar got together to organize this conference. That is just an indication of how interdisciplinary we are. Thank you.
Thank you so much, sir. Now, we shall begin our award ceremony. First, we have the sports category.
We have with us Dr. Pradeep Kumar Saikia. Kindly welcome Dr. Pradeep Kumar Saikia to the stage. Born in Hiloidhari village, Dibrugarh, Assam, he did his MBBS and MS from some medical college. He started his medical practice in Jorhat and is a noted surgeon of Upper Assam. His sports achievements are Best Jumper in AMC 1983, Runners-up in AMC 1984, represented AMC in University Sports Meet 1984, 1985 and 1986, participated in Masters Athletes, won various events in Masters Athletes, first position in 100 meters in All Assam Inter-District Masters Athletes Meet 2023, third position in 200 meters and long jump, participated in National Masters, selected to represent India in World Masters Meet Gothenburg, Sweden, participated in 100 meters, 200 meters and long jump events. His sports achievements and selection to represent India in World Masters Meet are notable recognitions. He is passionate about sports and medicine, a very dedicated and persevering figure.
Next, I would like to welcome on stage Dr. Joydeep Dey. A big round of applause.
ভিডিঅ' হয় তাৰপিছতো ভিডিঅ' চাৰিটা ভিডিঅ' আছে তিনিটা ভিডিঅ' চলাই দিবা Good evening, everyone. First of all, I must thank the organizing committee of Nebaoicon 2024 for felicitating me in this forum. I'm really thankful to them. Next. And it was actually, of course, I have been playing since my school days. And it was a great experience to be there in the international championship. And I have got lots of experience and I have learned many things in the field of games and sports, particularly in athletics. Actually, I had a dream since my school days to go to the international levels, which I could not do during my earlier age. And finally, I have achieved it at the age of 60. And it is that was my dream and I have fulfilled it. So thank you all.
Next, we would like to call upon stage Dr. Joydeep Dey. Please come on the stage, sir. Dr. Joydeep Dey is a multifaceted achiever, doctor, athlete, and musician. He is a doctor by profession, and his main interests have been athletics and music. He has won gold medal in 10,000 meter race, Assam Masters Game Association 2022. Bronze medal at 5,000 meter and 10,000 meter National Masters Game Thiruvananthapuram 2022. Silver medal at 10,000 meter marathon Asia Pacific Masters Game Jeonbuk, South Korea 2023. Silver medal at 800 meter run Doctors Olympiad Vijayawada 2023. He has been selected for World Masters Game Award. His conceptual song, Otithi, got nominated for Best Debut Male Singer, Best Lyricist Award at Rangoni Music Award 2023. He has been honored with Sporting Excellence Award.
I should mention Mr. Joydeep. He's a lyricist of Jubin Garg.
A pleasant, warm evening to everyone. Let me first congratulate respected Tapas Das sir, the organizing president of Nebaoicon, respected Anjana Sharma Vaido, Madam organizing secretary, Nebaoicon, and the most important, the entire organizing committee. For them, we are here together in one single platform with such a huge arrangement. I would like to thank the sound, lights, and everyone. At such an area where we are here today with a big historical background here at Sibsagar, at Assam. I express my gratitude to the Nebaoicon for giving, accepting, and giving recognition to the field of sports, which is a big thing for all of us, the sports people. And it will be, I'm indebted for that. To all the esteemed members, my teachers, everyone in this house, I've got a small gift for all of you. The gift is that it's called sports. Please make sports the best or one of the best companion or your friend to your life. Give every day a small amount of sports to your life. I can challenge, you will have a wonderful life in the future times to come, and you will cherish it in the later part of your life. Finally, I would like to conclude with a small line like, success is never or sometimes not be a happiness, but happiness is the key factor to success. Thank you so much. Long live Nebaoicon. This evening will be always remembered in my lifetime. Thank you so much.
Thank you, sir. Our next category is the Lifetime Achievement Award. This prestigious award honors an individual's remarkable contribution, dedication, and lasting impact on their field. This award was first introduced in the year 2004, which continued thereafter. Every year, we honor doctors with exceptional achievement in their profession. This year, we would like to honor 4 personalities with the Lifetime Achievement Award. First, we have with us Dr. Ambika Prasad Datta. Dr. Ambika Prasad Datta is a renowned medical professional with a distinguished career spanning several decades. Born on October 21, 1935, Dr. Datta's educational journey began with his matriculation examination from Tejpur Government High School in 1954. He then pursued his ISC examination from Cotton College in 1956 and later earned his MBBS degree from Assam Medical College in 1961. Dr. Datta's medical career is marked by significant milestones, including serving as a junior and senior house surgeon in ENT for 1 year. He joined the Central Health Service and served in the erstwhile NEFA for 6 years, covering 3 different places near the McMahon line on foot, a remarkable feat considering the challenges of the region. After the Indo-China War, Dr. Datta joined the Assam Health Steel Service in 1970. His contributions to the field of ENT are notable, particularly his role in establishing the ENT department at Tejpur Civil Hospital. He also served in Golaghat Civil Hospital for 3 years before being transferred to Mahendra Mohan Chaudhary Hospital, Guwahati in 1984, where he played a key role since its inception. Dr. Datta's illustrious career culminated in his retirement as Deputy Superintendent of Mahendra Mohan Chaudhary Hospital in February 2015. His dedication and service to the medical field are truly commendable. May I request Padma Shri awardee Dr. Ravi Kannan sir to kindly felicitate them. Kindly give a huge round of applause.
The citation here is like this. Respected Dr. Ambika Prasad Dutta, it is with great respect and admiration that we recognize your extraordinary contribution in the field of otorhinolaryngology. Your lifetime dedication, innovation, and unwavering commitment in improving patient care has profoundly impacted the countless lives. What sets you apart that you have rendered your service in a field with limited resources and your beneficiaries are the truly privileged citizens. Your achievements are a testament of patience and perseverance. From your tireless advocacy for otorhinolaryngology as a field of medical practice, you have truly redefined what it means to be a leader in medical sciences. As we confer you the Lifetime Achievement Award, we thank you for your invaluable contribution in the fields of medical services and for being a beacon of hope and knowledge. Your legacy will continue to inspire and guide generations of young medical graduates. Thanking you, all the signatories of Nebaoicon. Thank you, sir.
Good evening, everybody. Honorable President, respected dignitaries on the dais, esteemed delegates from the Northeast states, invited guests, ladies and gentlemen present. At the outset, I express my heartfelt thanks to the organizing committee, and I accept the award. I accept the award with deep gratitude and all humility. As I belong to the past, I want to share a few experiences with you in brief because of the time constraint. I have been in this discipline for the last 62 years. In the beginning, there was dearth of anesthetists, so in the 60s, 70s, the dearth of anesthetists, we had to administer anesthesia ourselves, playing the rural dual role of the surgeon as well as the anesthetist. We did it with the help of the ether can observing both operating and observing the patient during operation, monitoring his breath with a whiff of cotton and examining the pupils of the patient. And that was our only tool to administer anesthesia. Next, I come to the case of diphtheria. In those days, diphtheria was rampant. Nowadays, though it is rare, due to mass vaccination. I operated on many child with respiratory distress, and a surgeon of ENT at that time were on the tiptoe at what time a child with respiratory distress will come for help. And we had to perform tracheostomy on a large scale, and it was rewarding and satisfying for the surgeon, because a child coming with respiratory distress, battling for life. when you open the trachea with the scalpel with forceful expression, these excretions sometimes with the membranes of the trachea will come out, and the next moment the child will go to profound sleep. It was a very satisfying moment for the surgeon. Next I come to about the endoscopy. At that time our rigid endoscopes were only available, particularly with the esophagoscope. When esophagoscopy was done, it was very difficult sometimes, and it became an ordeal for the surgeon as well as for the patient. But nowadays, because of video endoscopy and flexible endoscopes, it is easier to do endoscopy. And previously it was removal of foreign bodies was the domain of the ENT surgeons. But nowadays anybody can, in other disciplines, can also do it. Then I will tell about the everybody knows that so many headache cases come to ENT because to the lay people they think their sinusitis is the cause for headache. But those cases, many of the cases are of migrainous in nature or neurogenic in nature or vestibular of origin. So we did a lot of antrum puncture in the past, and the washout was clear. And now we realize that those were actually not the cases due to sinusitis. And at that time only X-ray was the only tool to diagnose sinusitis. And this mucus, thickening of the mucus actually is not, cannot detect sinusitis. Now I want to tell something to the budding otolaryngologists and younger rhinologists, that you never be elated by praise, never be depressed by criticism, because we cannot cure 100% patients. We cure some, we comfort some, and we console some. Our duty is to serve with dedication, because our profession is the profession of dedication. That is not my advice, but a bit of suggestion. And time does not permit me to tell so many things, but I will conclude my short speech reciting the immortal verse. Sarve no, I don't know. Sarve bhavantu sukhani, sarve santu niramaya, sarve pochsanti bhadrani pochsanti, ma kachit dukkhamay bhavet. Let all of you flourish in your life. May all of you flourish in your life. May God bless us all. Herein I conclude my speech, and thank you very much for giving me a patient hearing. Thank you.
Thank you, sir. Next we have with us Dr. Pradeep Kumar Bordoloi, Born on 8 June 1944, Dr. Pradeep Kumar Bordole completed primary and secondary level schooling at Hibahagor. He passed MBBS from Assam Medical College, Dibrugarh in the year 1968. Following his internship and house surgeon job in AMC, he joined postgraduate studies and completed DLO in 1971 and MS in 1973. After this, he joined as medical officer in charge in Deaf Clinic attached to the Department of ENT AMCH in 1973. After 6 months, he got APSC selection and was appointed as resident surgeon in ENT department AMCH. He continued in this capacity for 3 years and then decided to quit the job as he heard clarion call from his conscience to serve the needy people from his birthplace Hibahagor. Till then, Hibahagor was without any ENT surgeon. He started his own practice and continued in the private sector since then and fulfilled the need of the community for a long innings of 48 years. He is a life member of AOI, life member of IMA, life member of Neboi, life member of Ahom Sahitya Sabha, besides holding the key post in many socio-cultural organizations of Hibahagor. He was elected to the post of President Neboi in the year 2006-2007. Dr. Bordole has a very different aspect of his illustrious personality. He is very much involved in the field of performing art. Being a brilliant actor, he has acted in several movies, namely Siraj, directed by late Dr. Bhupen Hazarika, Bordol Sila, directed by Dara Ahmed, besides innumerable dramas, stage shows, TV film, and serials. He has directed and written scripts for many stage plays, conducted acting workshops. His rich baritone leaves a lasting impression on his audience. He has several publications in his name. His article, Malignant Melanoma of Nose, was published in the Journal of Laryngology and Otology. Dr. Pradeep Kumar Bordole has been honored and felicitated by many organizations like Ahom Sahitya Sabha, Ahom Naitya Honmilan, Jatiyo Sangskriti Borbheti, Ahom, etc. He was conferred Lifetime Achievement Award by IMA Hibahagor in the year 2023. I would like to request Dr. Ravi Kannan sir to kindly felicitate him. Kindly give a huge round of applause.
May I request Dr. Pradeep Bordole to kindly say a few words?
Good evening, everybody. It is one of the most proudest moment of my life as I'm getting your love and blessings this evening. And for that, I am offering my heartiest thanks and gratitude to you all, to Nebai, and whatever I could do in my professional life as well as my literary and cultural life. Hope that with your blessings I will be able to go on further till my health and mind permits me. Thank you again very much to all of you.
Next up we have Dr. Arun Kumar Bhattacharjee. Born on 1st May 1944 in Sylhet, Undivided India, he has 40 years of teaching experience in medical colleges since 1970. He has been the ex-dean School of Medical Science, Assam University, India. He did his MBBS from GMCH, DLO from Maulana Azad Medical College in 1969 and MS ENT from GMCH. He joined Silchar Medical College as Registrar ENT in 1970 as founder member of the department. He retired as Principal cum Chief Superintendent, Silchar Medical College in the year 2002. Thereafter, he joined Sikkim Manipal Medical College for 1 year as Professor and Head ENT at Agartala Government Medical College, started the postgraduate teaching program there. He has popularized the subject of thyroid surgery and head and neck cancer surgery. He has been awarded the Haswati Lokmal Chandrais Research Endowment in 1994 for thyroid surgery research and presented the paper at first SARC International Conference at Nepal in 1995. He has been awarded the Fellow of International College of Surgeons 1992. He has presented numerous orations papers on various subjects in different academic forums. He has been honored with Lifetime Achievement Award by RIMS Imphal 2000. He has been the President Nebaoicon 2016, MCI Assessor for UG and PG inspection in 20 medical colleges. He was a regular member of college football and cricket team as wicketkeeper batsman. He has played for Maharana Club cricket team at Guwahati during younger days. At present, he is involved in the Kachar Cancer Hospital Society as governing body member. I would like to request our IMA President, Dr. Dilip Borua sir, to kindly come over the stage and felicitate Dr. Arun Kumar Bhattacharjee. Please give a huge round of applause.
A few words from sir.
মই বেছি সময় নলওঁ মোৰ প্ৰথম লাজ লাগি আছে যে মই তো যি কৰিছোঁ নিজৰ কাৰণে যেন কৰিছোঁ লাগে কি কৰিলোঁ মোৰ কি ইমান এচিভমেণ্ট তাৰপিছত আজি পেপাৰবিলাক শুনি মই গম পাই গ'লোঁ যে মই এচিভ কৰিছোঁ এই হিৰণ্য বৰা তাপস দাস পঞ্চী শৰ্মা ৰিংকু ৰহমান এইবিলাক আৰু বহুতৰ নাম আছে এই মোৰ ছাত্ৰ ছাত্ৰীবিলাক এই মোৰ এচিভমেণ্ট সেইকাৰণে মোৰ খুব ফূৰ্তি লাগিছে যে মই এই কথাখিনি ক'ব পাৰিম আৰু মই অসমীয়াত কেলৈ কৈ আছোঁ যে মই বেংগলীয়ে ভালকৈ ক'ব নোৱাৰোঁ আৰু ইংলিছটো ক্লাছতো মই ক'ব নোৱাৰোঁ আৰু মোৰ বয়স হৈছে শকত দেখাত আমি বডি বিল্ডাৰ আছিলোঁ আৰু ভুল কৰি মই অলপতে চুলিত ৰং কৰি পেলাইছোঁ হা কাৰণ মই যেতিয়া ক্লাছ লওঁ ডিব্ৰুগড় মেডিকেল কলেজত তেতিয়া মই ষ্টুডেণ্টক কওঁ মই কালি অলপ দেৰি হ'ব মই চুলিত ৰং কৰিম মই কিছুমান বস্তু লুকাই নকৰোঁ চবক কৈ কৰোঁ চুৰি কৰিলে কৈ কৰোঁ এনেকৈ আৰু যে মোক খুব ফূৰ্তি লাগিছে মানে জীৱনৰ এটা ৰিকগনিশ্যন আপোনালোকে দিছে আৰু আপোনালোকৰ বিহেভিয়াৰ আৰু অন্তৰংগ টান যিটো এইটো মই কেতিয়াও পাহৰিব নোৱাৰোঁ মই শিলচৰত কওঁ মই মাজে মাজে ফেচবুকত লিখোঁ যে আপোনালোকে বিহু কি বস্তু জানিবলৈ উজনি অসমত যাব লাগে ইহঁতক কি মানে কেনেকৈ মৰম কৰে মানুহক
এইবিলাক চাব লাগে, ৰেচপেক্ট কেনেকৈ কৰে। আমাৰ এই কালচাৰটো ওচৰৰ ষ্টেটৰ পৰা আনিব নালাগে, যিটো আপোনালোকে কৰে এইটো বহুত উচ্চ স্তৰৰ। আৰু হৈছে কেলে ইয়াৰ যে সাহিত্যৰথী লক্ষীনাথ বেজবৰুৱা, তেওঁ এই গভৰ্ণমেণ্ট কলেজৰ পৰা 1861 এণ্ট্ৰেঞ্চ পাছ কৰি তেওঁ কলকাতা গৈছিলে, গৈ ৰিপন কলেজৰ পৰা তেওঁ FA পাছ কৰিছিলে। তাৰপৰা বাকী হিষ্ট্ৰীত আপোনালোকে পঢ়িব জানিব, আচৰিত হ'ব কি মানে কি স্তৰৰ মানুহ তেওঁ আছিলে। আমি পঢ়োঁ, আপোনালোকে নপঢ়ে। আজি সময় নষ্ট নকৰোঁ, মই ক'লোঁ সেইটো ট্ৰেডিশ্যন থকা চহৰত আজি তাপস দাসে যিটো কৰিলে, মই অল ইণ্ডিয়া এছ'চিয়েশ্যনত প্ৰবেবলি গ্ৰেটেষ্ট নাম্বাৰ আমাৰ ছাৰে ক'ব পাৰিব, NN দত্ত ছাৰে। মই গুৱাহাটী মেডিকেল PG কৰিছিলোঁ, তেওঁ মোৰ থিচিছ গাইড আছিলে। আচ্ছা, তো সিহঁতে ক'ব পাৰিব যে কিমানবাৰ মই এই একাডেমিক ইয়াত লাগি থাকোঁ, মেক্সিমাম এটেণ্ডেঞ্চ লাগে মোৰ আছে ইয়াৰ পৰা, কিন্তু পাছত বেমাৰৰ কাৰণে মই নোৱাৰিলোঁ। মই বক্তব্য শেষ কৰিছোঁ এইকাৰণে যে এই কনফাৰেন্সত বেষ্ট কনফাৰেন্স মোৰ মতে লাষ্ট 20 ইয়াৰ্ছত তাপস দাসে কৰিলে, কনচিডাৰিং স্মল ইয়ে। আর তাপস দাস আর সাইন্টিফিক সেশনটো খুব হাই স্ট্যান্ডার্ডৰ হৈছিলে। এইটো ৰিংকু ৰহমান চাগে এইটোৰ চাৰ্জত আছে, মই যিমানখিনি জানো। এই কথাখিনি হৈ মই কৃতজ্ঞতা জনাইছোঁ, মোৰ ইম'চনেল হৈ পৰিছোঁ। মোক ইমানখিনি ৰিকগনিশ্যন, কাৰণ মই খুব ইয়ে মানুহ, পাব্লিচিটি একদম কৰিব নাজানো, কিন্তু আপোনালোকে ঠিক বিচাৰি ওলাইছোঁ মোক যেন লাগিছে আজি। ৰবি কাননক মই জানাইছোঁ, তেওঁ আমালোকে আনিছিলোঁ, আনি আমাৰ প্ৰেষ্টিজ তেওঁ বঢ়াইছে। আৰু আজি যে তাপসে তেওঁক লৈ আনিছে ইমান কষ্ট কৰি, ৰবি কাননকো মই অন্তঃস্থলৰ পৰা কৃতজ্ঞতা জনাইছোঁ। থেংক ইউ।
Thank you, sir, for such a warm and joyful speech. Now, next we have Professor Pradul Hazarika for the Lifetime Achievement Award. Professor Pradul Hazarika did his MBBS, DLO, MS, FRCS. He's a true son of the soil. He was born in Hibohagar, and after completing his initial studies at Hibohagar, he joined Assam Medical College in the year 1966 and completed MBBS, DLO, and MS degree, all from AMCH. Then he worked for a short stint in AMCH and set out for a wider horizon outside Assam. He worked in various hospitals and ultimately reached Kasturba Medical College, Manipal, where he completed his long career of 30 years and retired as professor and head and director of postgraduate studies of the Department of ENT and Head and Neck Surgery in Kasturba Medical College, Manipal, India. He has over 30 years of clinical teaching experience, both at the undergraduate and postgraduate levels, with over more than 100 publications in various national and international journals. He was selected as an international guest scholar by the American College of Surgeons in 1986 and has traveled widely to the US, Australia, UK, and Malaysia, Switzerland, Mauritius on various fellowship programs. He was awarded EMARC Award for the year 1989. He was awarded with International Cancer Research Technology Transfer Award from International Union Against Cancer, Geneva, Mamadi Sodavar Cancer Fellowship by the New York Community Trust, New York, Certificate of Appreciation from Impact India Foundation, an international initiative against avoidable disablement promoted by the UNDP, UNICEF, and WHO in association with the Government of India. He has conducted various operative workshops in India and abroad. He was chairman of editorial board of Indian Journal of Otolaryngology from 1996 to the year 1999. He was appointed as external assessor by University of Malaya, Kuala Lumpur, Malaysia from August 2000 to April 2005. He had done pioneering work in surgical rehabilitation of alaryngeal patients. He has also introduced voice prosthesis known as HRA prosthesis. He was the first surgeon to introduce nucleus 22-channel nuclear implant in India in March 1995. The surgical team headed by Dr. Hazarika has popularized skull-based surgery in India during the late 80s and early 90s. He was instrumental in introducing KTP 532 laser for the first time in a teaching institution and had carried out extensive laser work. He is the author and co-author of textbook of ENT and head and neck surgery and wrote books on skull-based surgery, clinical methodology, endoscopic sinus surgery. Professor Hazarika is presently working in Namcare Hospital, Guwahati. Now, I would like to request Professor Dr. Anandotto sir to kindly come over the stage and felicitate Professor Produl Hazarika. Sir, please come over the stage.
Well, I'm very much honored and I'm humbled in receiving this lifetime award given by the Sipsagar branch of AOI, and extremely happy to receive the special award in my special place in my hometown. And I really dedicate this award to my parents, Mr. Lalit Chandra Hazarika, and my mother, Mrs. Sabati Bala Hazarika, and also dedicating to my very affectionate brothers. Mr. Rajiv Loshan Hazarika, who has accompanied me along with his wife, my Bhabiji, my next brother, R.M. Hazarika. He could not come with me because of his own work in Guwahati. And Mr. Ram Mohan Hazarika, he could not come. Then Mridul Mohan Hazarika, of course, he is not there. Then Z.M. Hazarika, Gokul Mohan Hazarika, my younger brother, he has come. And my youngest brother, Sanjeev Hazarika, has come. And also, I dedicated this particular award to my loving wife, Mrs. Rima Hazarika, who accompanied me, is here. And also I was taking this opportunity to remember my teacher, Professor B.R. Das, he is no more, and Professor R.N. Latta, Professor Hakim A. Hakim, and one of my another teacher, Dr. Pradeep Bordoloi, who was very, very dynamic in particular time. Then other Professor Dr. Satyajit Rai, Satyajit Datta, and they were, and Akhil Sharma. They have taken a lot of pain in teaching me and making me a good academician. And my achievement is basically achieved by Professor S.K. Kakar from All India Institute, then Professor A.L. Mukherjee, Dr. Ramesh Deka. They were really people who put me in the place, and what I am today, they take the maximum credit from my side. And I really thanks the dynamic ENT surgeon from local Sipsagar town, Tapas Das, Anjali Zarua, and Dr. Anjali Borua, my senior, who is the president of the President Nebai. And I really thank you very much for giving me this opportunity. And I also thank all and each and every one of this society. Thank you very much. May God bless you.
I am surprised that I have been asked to talk something here. And I am very happy to sit by the side of my good friend. I had been to Manipal, and now he has moved to Guwahati. I have become very nostalgic because the Nebaoicon was first started by us. Dr. S.N. Sharma was the principal. I was in the medical college. Dr. Subodh Goswami was my student, also he my colleague. We three actually endeavored to start the first Nebaoicon there. And Nebaoicon in medical college, I was there for some time. Medical college did not have an auditorium, did not have big classroom. I don't know how did we manage, but it was a pleasure of starting the first Nebaoicon, and it has been appreciated. And I have got a pleasant story to tell you. That second conference was started in Silchar. Silchar by Dr. Sidas. And then he thought that I am a very enterprising man and organizing secretary. He wanted to give me very good accommodation. He probably asked the organizing committee member that give some free accommodation to him, very good free accommodation. And then we arrived there. That's a very interesting story. And I found a free accommodation in the classroom. And my wife was a professor of Cotton College. And classroom was decorated very nicely. And Cotton College also does not have attached toilet. Guwahati Medical College also does not have attached toilet. So she shouted at me, "What is this? Why you have brought me here?" I did not expect that I shall be given a classroom. And then Arun Bhattacharya, he calls me Dada. I call him, save my marriage. And he took me to a hotel and we stand there. And because of his help, we have completed 50 years of marriage. Thank you so much, Tapas. And Rinku, where is Rinku? Rinku, actually I have come here for Rinku because she has been calling me so many times, and I had a very nice supper, dinner in her house with my whole family some time back. Thank you.
Thank you.
Thank you so much, sir, for such a warm speech. Now I would like to request our Organizing Secretary Nebaoicon 2024, Dr. Anjana Sharma, to kindly give the vote of thanks.
Very good. Sound. A very good evening to everyone. Respected dignitaries on and off the dais, and members and delegates present here. It's a very tough job to give a vote of thanks. Still, first of all, I'd like to thank our guest faculties, especially Padma Shri Awardee Dr. Ravi Kannan sir, who took so much of pain to reach here today. And also I would like to thank Bharat Deshmukh sir, Dr. Srinivas Dorasala and Amitabh Roy Choudhury, who will be reaching tomorrow. And all the faculties and all the delegates present here. Because of your presence only, we can call it as Nebaoicon is a success. And we have more than 250 registration for the conference, and we have more than 150 faculties in the form of speaker, moderator, chairperson, and it's a great thing for us. I'm really speechless for your cooperation, and I would like to thank the reception committee members and mostly the friends of Nebaoicon and all the pharmaceutical companies, especially the Signova group, who has helped us a lot in the final moment. And I would like to mention here that they are helping us to organize multidisciplinary credit point CME every year in Sivsagar. It's a great event for us. We organize every year in the month of June. And I also thank all the pharmaceutical companies, and also special thanks to ONGC for giving us this beautiful venue, and also the persons behind that venue is the Bishwajit, the Manas, and Vicon, and then audiovisuals, and Saroj Jain and his team, and also the sound, and and also the cultural team, because I don't miss that cultural event. Two beautiful voices will be presented before you today and tomorrow. One of is the voice of Assam. She'll be coming soon, and don't miss the cultural event. And last but not the least, I must congratulate the postgraduate students. They joined this conference in a large number. We have more than 45 registration from the postgraduate students, and we have almost 30 papers and Swami Vivekananda and poster presentation, and really you made us proud. And thank you everyone, thank you. Here with these words I conclude my speech. Thank you everyone.
Thank you, ma'am. Now, I would like to end this inaugural ceremony by playing the national anthem. I would like to request everybody to kindly stand up. I would like to request the technicians to kindly play our national anthem.
गणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you everyone. Now, we will be proceeding with our scientific session with Professor Sida's oration. Our chairpersons will be Dr. N.N. Dotto sir. Sir, kindly stay on the stage, sir. Yete thakibo neke? Oration? Bohi jaok. Apuni bohi jaok.
Chairperson tat thake.
Jaok, tat.
Chairperson to
Hai, hai, hai.
Sir, apuni
You stay on the stage. You will be the speaker. Oh, you'll get the speaker. Oh,
I'll get the computer.
Computer, okay, okay.
I could not load the presentation. The thing
You
is,
have in the pen drive?
it would not load it. I tried it, so I went and got my computer.
Okay, okay.
I put the computer.
Let's move on with our scientific session by continuing with Professor Sida's oration. Chairpersons would be Dr. N.N. Dotto, Dr. Quddus Ahmed, and Professor Dr. Anjali Borua. And our speaker is esteemed Padma Shri awardee Dr. Ravi Kannan. Sir, please come on the stage. I would like to make a small announcement. Our journals are available at the reception counter. You can please collect your copies from the reception counter.
It's our great pleasure to invite Ravi Kannan, famous person with humble attitude. Here I would like to say a few words. Recently Ratan Tata died, and I wanted to have a condolence meeting there. And some of the officers said, why do you want to have a condolence meeting for Ratan Tata? Do you know him? Well, I never have met him. I have never had seen him. I have seen his photograph. But he was the most benevolent industrialist of the whole world, I should say. Because he had 50 lakhs crores of rupees, but he has helped many institutions. He has built many institutions. And after his death also, they are going to have a 200 crore animal hospital there in Bombay. Why I am telling? Because here is our Ravi Kannan. He does not have that much money, I know. But he has got such a big heart. I have heard a lot about you. I have not personally met you. That you see the patients with full empathy. And patients, I have read it. And that patients like you, like anything. And it is our pleasure to welcome you here to give the oration. And actually, though I operated thousands of operations, but I have never done any cancer surgery. Here is Dr. Quddus Ahmed. He is a famous onco-surgeon. I give the mic to him.
Thank you, sir. Without any further I do. Dr. Ravi Kannan has put up his presentation, so I'd like to request you, Sir Dr. Ravi Kannan, to please go ahead and deliver your oration. Thank you.
Thank you, sir. Thank you for
Taking the war against cancer into the community. I think that is something which you need a lot of, I think we all need to put our hands together and congratulate Dr. Ravi Kannan for his work in the community in the war against cancer.
Thank you, sir. Thank you very much for the introduction. And thank you to the organizers once again for inviting me to deliver this. I think it's a privilege to deliver an oration honoring one of the greatest teachers in otolaryngology and head neck surgery from the state. Thank you very much. So it's 50 years or more since the President of the United States in the 1970s declared war against cancer. And in the last so many years, many things have happened. A lot of technology has grown. We've learned many new skills. Many drugs have come in. But what does not change is unless we involve the population, the communities that we serve in this war against cancer, we will probably never be able to control cancer and treat it successfully. Like many of you here, I work in a smaller city in the region, in Silchar, and like many of you, Silchar has its own share of problems in travel, in transport, in many ways, those problems are probably no different from the problems that you face. So one of the things that poor people will do, Dr. Tapas wanted me to speak on what we have done in the past, but what I would like to focus on is, while I would honor what he requested, I would like to speak about what is happening now and where we will be in the future. So poor people, the commonest, they resort to a variety of ways in order to complete treatment. They will resort to distress sales. They will resort to borrowing at exorbitant rates. They will depend on public charity, and the easiest thing that they will do is disappear from the hospital. They will abandon treatment, fully understanding that it will result in death, but they will accept it because they don't have and so in order to improve compliance, we resorted to many conventional and some non-conventional ways. Some of it was foolish, most of it was pretty organic and knee-jerk, and some of it works, many of it did not work. But overall what we did was to actively brand ourselves as pro-poor, every opportunity, because poor people are often afraid of going to our hospitals because they think that if they go to a hospital they will lose all their money and they will be on their streets, and they need to be reassured at every point of time that the organization is truly pro-poor. And then we adopted a whole lot of cost reduction strategies for poor people. Time lost coming to the hospital and going back is of vital importance. Every day lost is wages lost. Now over the years, initially I was a great skeptic of technology. Over the years we have started using technology extensively, and then now our current passion, which is what I want to focus on, is decentralizing care. So we put in place a whole lot of pro-poor measures, like reducing costs, reducing overheads, providing a no-frill service. We don't have fountains and marbles and things like that. And then many of our colleagues multitask. We try and remove costs as much as possible, and despite low cost, no cost treatment, no cost boarding, lodging, at one point of time we found that not even 30% of our patients were completing treatment, and that led us on a perennial question as to why people, even though treatment is offered for free or at very low cost, even though boarding is offered, lodging is offered, why is it that they are not? What are the barriers? And so over a period of many years we realized there are so many barriers that prevent people from accepting and completing treatment. So we started providing ad hoc employment, we started calling them, we started giving appointments, we started satellite centers, we started making home visits. Each of them led to some improvement, but then even today, you know, after so many years, nearly 30% of our patients don't complete treatment. Then we resorted to a whole lot of reducing times for treatment. And so our target is patient comes today, within the next 24 hours, the diagnosis, staging and treatment plan must be ready. And to a very large number of about 70-80% of the time they're able to do this. All our pathology, for example, works on frozen sections. So we see a patient to see today, the same day the blood biochemistry, X-ray, ECG workup is done. The next day morning they will have their endoscopies, biopsies. They will go on to have their imaging. All our pathology works on frozen sections. So by the time the patient comes in the afternoon, the pathology report is ready. We also resort to a lot of task shifting. So, you know, we don't have a full-time radiologist, and so a lot of CT-guided biopsies are done by trained technologists, and we actually compared the outcomes of CT-guided biopsies of lung lesions performed by a radiologist and performed by a trained technologist, almost 300 biopsies on each side, and we found no difference in the yield and no difference in the complications rates. Technology is a great leveler. I like repeating this everywhere. So many things, you know, COVID has taught us many things. So today a lot of learning, teaching happens on the net. We also have used technology to reach out to all our satellite centers, our home care programs. More importantly, you know, in the hospital we don't have a critical care specialist. Our ICUs, initially one of us as surgeons would be physically stuck to the ICU, and we would not. So then, you know, somebody came to us with a proposal for using cloud technology to provide physicians on the cloud. And initially, you know, we threw out that proposal because I, with my limited understanding, could not understand how a doctor who is not in the ICU can take care of the ICU. That after a few months, that proposal came back and we decided to experiment with it. So we put about 4 or 5 high definition cameras in our ICU. And these cameras watch every single patient. Every single patient monitor is captured and transcribed into a paper document. And the cloud, initially, everything, a bunch of cloud physicians sit in Bangalore monitoring patients. Initially, every advice the physician would give would go through us. Over a period of time, the sisters became very comfortable, and today we hardly involved in the care of critically sick patients in the hospital. And believe me, it saves lives. In the middle of COVID, it was pouring rain. My administrative officer, Debu's sister's father-in-law, had a complete heart block, and he was in congestive failure. He came in the middle of the night. It was pouring rain, and because of COVID, no hospital would accept him. Debu asked me, this man is in failure, what shall we do? I said, okay, we have this facility, bring him in. He came in with a saturation of less than 50%. The cloud physician stabilized him through the night. Next day morning when we went to see him, that man was sitting up having breakfast. He went, had a pacemaker inserted and went home. Another incident that happened almost a year ago, we did a hemicolectomy for somebody. For some reason, the patient was trending towards the cardiac arrest. Before the cloud physicians could warn the nurse on the ground, the patient arrested. Patient was revived. 5-10 minutes later, patient arrested a second time. Revived again, connected to a ventilator. 5 days later, the patient arrested a third time on the ventilator. Revived a third time, patient is on follow-up. And so technology, if we use wisely, you know, has tremendous benefits. Today with AI coming up in a very big way, I'm very hopeful that in the future a lot of tasks that require physical labor can be sorted out using artificial intelligence. But what excites me most today is taking the care as close to the community as possible. See, in my father's village, we used to have that doctor who used to go from house to house with a briefcase. He would sit at home, have coffee, treat the sick person, dispense medicines, and then move on. He would be a part of the community, a part of the family. He would attend births, he would attend deaths, he would do many things, but he would also take care of the sick person. Today, with urbanization in smaller towns in the south, we used to have, every street used to have a small petty shop. We used to call them Nadar Kadai. So they used to sell a whole lot of knick-knacks that were used by the community, groceries, vegetables, whole lot of things. Today with the availability of supermarkets, all these shops have disappeared. We have big sprawling malls and everybody has to go to a mall. Same way, if you in Chennai, I remember we have a street called Punamali High Road. The whole street had so many nursing homes named after Halstead, named after Harvey Cushing, named after, and they used to provide a lot of invaluable service. And with the development of all these multidisciplinary hospitals and corporate style hospitals, all these hospitals that were doing amazing community service have slowly gone out of viability and have disappeared. And so the old time physician visiting homes concept, but unfortunately you cannot take CT scans and radiation machines to people's homes. They have to come to a hospital. But what we can do is to take the hospital, the clinic, the facility as close to the patient's home as possible. And you can have a central hospital, a hub if you call it, and have spokes that will go out into the, what we are envisaging is, we as a cancer center, we will have 4, 5, 6 satellite centers that will do, except probably for radiation therapy and major surgeries, that will deliver all the services that will happen in the hospital in the satellite center, but we are looking at them as pure daycare facilities at the moment. And each of these satellite centers we are looking at populating with what we call PEP centers. I will explain that to you in a minute. So in 2016 the government of India came out with its screening guidelines, and the government envisages that the ASHA will mobilize the community to go to a sub-center where the A&M would screen them for diabetes, hypertension and common cancers. Now on paper, while this looks attractive, actually the mathematics does not favor this. Each A&M is responsible for a population of about 5,000. There are 2 A&Ms in every sub-center, and they are riddled with a whole lot of other responsibilities. They have to deliver babies, they have to keep books, they have to go on sanitation drives, they have to do immunization, whole lot of things. And if they have to screen a population of 5,000, it's not going to happen. So what we decided was we would train the ASHA to do the triage examination. She would be the first port of call, and each ASHA is responsible for about 1,000 people, out of who about 350 or 400 people would be screen eligible. And so our calculation was, if the ASHA were to look at one individual in a day, in a year she would have done her whole population. The other thing we decided was, see, we learned from the screening programs that happen across the country, most screening programs do have very poor compliance rates. And so we said this happens because people who are on daily wages cannot be bothered to go about to a sub-center to get examined for a disease that they think they do not have. And so they don't want to lose their daily wages. So we said the ASHA who hails from that village will go door to door, home to home. She knows when the population will be at home, and so she will carry out the triage examination in the homes of the population. And we were careful to say that she is only looking for abnormalities. We did not talk about cancer detection. What we taught the ASHA was to look at the mouth and say normal, abnormal. Feel the breast, say normal, abnormal. Inspect the cervix, say normal, abnormal. Take 1 CBG and do 1 blood pressure measurement reading. Now, and then we actually gave them all Tata Trust helped us procure tablet computers for all of them, and we gave each of the ASHA a tablet in which to fill up a questionnaire. We realized many of them don't know to read and write, so we put pictorial representation so they could just mark on the picture. Many of them found it difficult even to do that, and so a family member, a daughter, a daughter-in-law, or a sister, somebody else would help them do that, and we were happy with that because another generation is getting empowered. So what happened was, we chose one health block with a population of about 2 lakhs. Screen eligible population was 66,000, out of who the ASHA were able to reach out to nearly 50,000 people, out of who more than 47,000 actually went through the process. The compliance was more than 90%, which is almost unheard of in any screening program. And what happened was, I'm just sticking to head and neck cancers because that would be of interest to you. So she examined out of 46,000 people. we said all the abnormals we would examine, and we said about 20% of the normals we would re-examine to make sure what the ASHA is saying is correct. We were not able to do 20,000, we only did about 4% of them. But then what happened was, when we examined people who the ASHA designated as normal, we did not change anybody. One or two, hardly anybody's findings were changed. When the ASHA said the oral cavity looks abnormal, a substantial number of times he said, no, it is normal. So look at what happened. She examined 46,000 people, out of whom she found about 8,000 or 9,000 people to have some anomaly. And then we asked them to come to a sub-center. Nearly 3,000 of them came to the sub-center. And then we looked at them, and when we said you come to the hospital, 50% of them dropped out. While the compliance at home was 90%, while the compliance in the sub-center was nearly 75%, compliance in the hospital was less than 40%. Anyway, at the end of 46,000 people being examined, we picked up 49 cancers and 147 pre-cancers of the oral cavity. Likewise, we had other things in breast and cervix also. So out of these 43 people who we picked up with oral cancer, with head and neck cancers, half of them completed treatment, and about one-fifth of them defaulted treatment. They did not come back for treatment. In the first round of screening, as expected, we had a whole lot of advanced cancers. Now what also happened was, when we examined these 46,000 people, we found nearly 4,000 people with diabetes and or hypertension, which is a much larger number when compared to the cancers that we detected. So then what we said was, we took up another health block and said, this is door-to-door physical examination. What happens instead of physical examination? We create a blitzkrieg of information. We tell everybody about cancer, lifestyle, diet, tobacco, and and then implement the same questionnaire and encourage people to self-refer themselves for screening. In other words, we were trying to promote a health-seeking behavior. So picked up another health block, again 2,10,000 population, eligible population was 66,000. The ASHA was able to reach out to about 50,000 people. When this time we were smarter, we did not insist on our questionnaire. We chose the government's CBAC form, Community Basic Assessment Checklist form, which is mandatory in the sub-centers. The ASHA have to fill it, and they are paid an incentive of 5 rupees or 10 rupees for form filled. So the ASHA filled up about 50,000 forms, out of whom we found 4,500 entries had some anomaly, some abnormality. So the ASHA encouraged these people to come for evaluation. So out of the 4,500, we were able to examine nearly 3,000 of them, and we had about 102 cancers and about 800 people with pre-cancers, mainly oral pre-cancers. Out of these 103 cancers, about half of them, about 45 of them were head and neck cancers. Again, when we looked at the compliance, we found half of them completed treatment and the remaining did not complete treatment. But what we realized is, in contrast to door-to-door physical examination, creating information and promoting a health-seeking behavior probably works equally well, and probably the amount of expense is less, the labor is less, and so reaching out to the community may be better if we resort to intense awareness creation. Then we thought this awareness in Katlichera happened only with the health department. We worked only with the health department and the ASHA. Now our population control program, which started in the early 1970s, took 50 years, and today the population is starting to decline. But this happened because everywhere we had, information. In the cinema halls we had Hum Do Hamare Do. In the back of the autos, in the buses we had Hum Do. Everywhere there was talk of population control. So we said the same information blitzkrieg that the ASHA created, what happens instead? We have the ASHA also doing it. We have the schools also doing it. We have the police doing it. We have the Anganwadi. We have the elected Panchayat Raj people. What happens if we have multiple groups of people promoting health awareness in the community. Now we wanted to see how we could approach the government for this. We realized when we were doing the research that in 2016 or 17, the government has actually come forward with a proposal for multi-sectoral convergent messaging. I don't know what happened to the government program, but we quickly, when we went to the district authorities, we said this is the government's program that we want to implement, and quickly they all caught on. And so now in Lakhipur, again a similar population, 2 lakh some population, we are trying to reach out to everybody, but this time we are trying to use different arms of the government to try and create awareness to see if this will improve the self-referral rate for evaluation. The other thing we are also trying to do is to see if in the government sub-centers and the PHCs, a lot of these programs, the biopsies can be done, the smears can be taken, the HPV testing. So we are trying to see if we can integrate this with the government. The other thing that we are trying to do is in Dima Hasao, all of us know access is so difficult. We travel to across the Jinam Valley on motorbikes, and that journey is such a bone-racking, nerve-wracking journey. Many places, for 10 kilometers took us nearly 3 hours on a bike. And so that's an area where we are looking at a modification of the same program. We are saying we will do this awareness, but instead of the community coming to a sub-center, we will travel from sub-center to sub-center. So GE gave us a vehicle, and now we just took this idea from the boat clinics that happen along the Brahmaputra in Upper Assam. So we said we will modify that, and we will have a traveling cancer clinic that will go from sub-center to sub-center to sub-center, trying to look at cancers and pre-cancers and other non-communicable diseases. Ultimately, what makes sense is cancer is caused by tobacco, areca nut, alcohol, dietary preferences and habits, and lack of physical activity, and some infections and inflammations. Only 4 or 5 causes of cancer. Now if you look at heart disease, diabetes, tobacco, alcohol, dietary practices, lack of physical exercise. We look at stroke, tobacco, alcohol, dietary practices, lack of exercise. We look at whole lot of diabetes, whole lot of non-communicable diseases are caused by the same set of 4 or 5 factors. And in addition, diabetes increases the risk of some cancers, hypertension. So some of these non-communicable diseases increase other non-communicable diseases as well. So when we go out to prevent cancer, when we go out to detect cancer early, we are actually promoting health, because when we modify our diet, when we exercise regularly, when we reduce tobacco consumption, when we reduce alcohol consumption, we are reducing cancers, but we are also reducing a whole lot of other non-communicable diseases, diabetes, hypertension, cardiac disease, stroke, renal failure, whole lot of things. And so we are trying to promote health in the community. And so that is what we are trying to see if this will happen in Dima Hasao. The other thing that we are also trying to reach out to the community is through our home care program. Home care is essentially meant for people on palliative care who are dying and who are not able to come to the hospital. So what happens is we have a one man on a bike home care team. We don't have a driver with an ambulance, with a social worker, with a doctor, we don't have that kind of facility. So we have just one man with a backpack. On a bike he travels across the region. Each of those 4 districts around us, we have 2, 3, 4 people who do the home care program. And what happens is, as part of the home care program, when we go to villages, what happens is the whole village community will gather to see what is happening in this person's house. So after the home care program is done, after the ascites is drained, after whatever has to be done is done, we gather the onlookers and talk to them about health promotion. We would do the same thing what the ASHA does in the community. And through this home care, we call it PEP, Prevention, Early Detection and Palliative Care. Prevention and Early Detection, piggyback rides on palliative care. So now the interesting question came up, when we were finishing the Kartlichara project, one of my nurses asked me, sir, you go into every community, start these programs, and when the project is completed, you dust your hands off and say project over. Is it justified? Because the community already has expectations raised. They already think something is happening, and they look forward to us going and training and teaching and helping them detect cancers early. So then we started wondering what happens if we do this. It's not ethical to get out. So now we looked at several models, and finally we said in Kerala we had this neighborhood networks of palliative care. And what happens is the whole of palliative care in Kerala is delivered through these neighborhood networks. None of them is hospital driven. The networks, I actually went to see some of them in Calicut and in Malappuram. The community raises resources, the community pays the doctor, the whole thing. And this happens because palliative care, Kerala is an educated society. Kerala has more money. But then palliative care is a tremendous necessity. Everybody is growing old, everybody is having a whole lot of other diseases, and need for palliative care is, and the leadership in palliative care in Kerala was able to disseminate this information. So as a experiment, we are trying to see, now that the Katlichara project is over, we are trying to see if we can create a network for palliative care in Katlichara. We have a whole lot of family members of patients that we have treated, and while they were getting treated, they learned a whole lot of skills. Now the patient is either cured or patient is dead, the skills are now lost. So we are trying to see how we can work with the Skill Development Council to accredit the training that this home care person has got. And we are trying to see if we can piggyback ride health promotion on the back of palliative care. That's an experiment to which I do not have an answer at the moment. Now, I really think that all of us have the opportunity to serve, and that is a gift. But to be actually able to deliver is a real privilege. All of us as doctors, the organizers of this meeting have dreamt, they had a dream, and they dared to dream to do something here. I think all of us together can actually dare to dream to see if together all of us can make a difference in the way we look at health and sickness and take care of people. We're all clinicians, and so we are all in the healing profession. We treat, we operate, we do many things. But we are also researchers, so we collect data and come out with causes of cancer, causes of COVID, how to prevent. We talk of a lot of things. We're all teachers. We mentor youngsters, we mentor colleagues, we mentor juniors, we do a whole lot of things. But I think the biggest opportunity that all of us have together is of being change makers. And together, I think we can really look at the way we change the way cancers are taken care of in the community. Thank you very much. This is thank you in different languages spoken at the Institute. Thank you. There's a short video, we can skip it. Thank you.
I would like to request Dr. Kripamoy Nath to do the honor.
Ravikant, we are very happy that you are here in Assam. And I pray to God that you be here and serve the society.
Thank you, sir. Thank you.
The way Ravikant has mobilized for his limited resources and really managed to get, juice out of a dry fruit, you might say, is something, the work he is doing in the community. I think that is the reason why he has been given the Padma Shri by the government of India, and also subsequently the Ramon Magsaysay Award. So
I'd like to scientific chair to felicitate from organizing committee.
Sir, you're the real healers. So we are proud of you. So as you are in Assam, I think for the whole life you will serve the people of Assam. And it's a request from all of us to see you serving the people of Assam who are in need of actual, service. Thank you, sir.
I request the chairpersons to kindly come forward to the felicitation corner. Dr. S.N. Mukherjee will do the felicitation. I request Dr. N.N. Datta, Dr. Kudus Ahmed and Dr. Anjali Borwa to kindly come forward to the felicitation corner. Dr. S.N. Mukherjee will do the felicitation. Next is the Professor Thaneswar Borwa oration on the topic pharmacotherapy of vestibular disorders. The chairpersons are Dr. Biraj Das and Professor Dr. D. Das. The speaker is Dr. Srinivas Dorasala.
May I request the chairperson to take the chairs?
This is Professor Thaneswar Borwa Memorial Oration, and it was established by Professor Borwa himself. So regarding Professor T. Borwa, for elders everybody knows him, but for juniors they may not be knowing. So Professor T. Borwa passed MBBS from Assam Medical College in the year 1956. Then after passing, he had been to Edinburgh and London, and he did his first years from Edinburgh and DLO from London. After passing, he was there in London for senior residency for 7 years. After that, he came back to Guwahati, and he joined as an assistant professor in Guwahati Medical College. Then after probably your PG, no? Which year? 1984, he came to Assam Medical College as a professor and head of the department, and he served this institute for around 10-15 years. He retired in 93 probably, and he did the second ENT conference at Dibrugarh, as I already mentioned in my speech. So it was dedicated in his name, and tribute goes to him. Thank you, Dr. Dorasala.
I'm happy to introduce my guru, Dr. Srinivas Dorasala. He is MSc ENT consultant at Ananya Healthcare, honorary professor at Jawaharlal Nehru Medical College and adjunct faculty at Yanapia Medical College. He has been awarded the inaugural Dr. P. Ghosh Award for Innovation of ENT by Delhi State AOI. He introduced microvascular free flap surgery in MS Ramaya Medical College, had a special interest in complex airway surgery, and contributed towards the establishment of cadaver-based advanced surgical skill lab in MS Ramaya Medical College. His first key innovation is a true point-of-care video nystagmography system, which has more than 700 installations across the globe so far. He has also introduced point-of-care high-precision posturography with robust diagnostic and rehabilitation modules for easy, accurate, and rapid assessment of functionality of the 6 semicircular canals. He has introduced a functional head impulse test device as a new advancement in the traditional video neurostimography. He has introduced cranio-oculography, which adds head movements measure in addition to eye movement measures. He runs the 3 months mentored learning course in Vertigo for ENT, neurology and audiology professionals. So far, more than 700 doctors and professionals have completed the 3-month course under his mentorship. From our Northfields also, a lot of people has gone through these courses. Over to you, sir.
Thank you, ma'am. Thank you so much, sirs. Thank you, ma'am. So, very, very good evening to all of you. We will end the day with pharmacotherapy of vertigo, unbalanced disorders. Okay. Now, this is going to be different clinical scenarios and what best you can do for them. What are the options is what I'm going to be covering this. Acute attack of vertigo, flunarizine. Keep 10 milligram regular flunarizine tablet in the mouth and wait for it to slowly dissolve. This is an option. Why? Traditional teaching is that flunarizine is a prophylactic drug for migraine, but it is a very effective agent even to stop acute episodes of vertigo in vestibular migraine. It is also an effective agent to stop acute headaches in migraine. Acute attack of vestibular migraine, including positional vertiginous migraine crisis where the person is migrainous and each and every time they turn right, left, up, down, sit, they vomit, lie down, they vomit, they turn to the right, they vomit. That kind of positional vertiginous migraine crisis also can be controlled by flunarizine. The reason for keeping the tablet in the mouth rather than swallowing it is these people are nauseous, okay, and they can actually end up vomiting and you don't know whether the tablet is absorbed or it was thrown out. Therefore, and though this tablet is not marketed, is not told as a tablet that gets absorbed in the mouth, my personal experience tells that it can be absorbed just by keeping it in the mouth. The next choice for acute attack of vertigo is dexamethasone, and this is not about intratympanic injection. I am talking about intravenous dexamethasone. 8 milligram IV injection. Especially when vertigo is not controlled after prochlorperazine or promethazine. Generally, the tendency is any person comes with an acute attack of vertigo, we give them an injection of prochlorperazine or a tablet of prochlorperazine. After one injection of prochlorperazine, if the vertigo is not controlled, we really do not feel like having an option of repeating the prochlorperazine. The reason is the huge incidence of extrapyramidal side effects that the second injection of prochlorperazine will have, and that can be more as a experience to the clinician that can appear more devastating than the actual vertigo itself, because the extrapyramidal side effect, the patient making bizarre neck movements and all those things are more scary both for the patient and for the family members than the vertigo itself. So you can't afford to repeat a prochlorperazine, but in that time dexamethasone comes as a rescue because that is very effective in controlling acute attack of Mukherjee sir. Okay. For the control of single episode of vertigo in pregnancy, especially in the second and third trimester, again dexamethasone is beautiful. Sorry, Fukan sir. Okay. End of the day, Fukan sir became Mukherjee sir became Fukan sir. Okay. Sorry. Control of acute vertigo in children, make appropriate dosage adjustment using dexamethasone. I need a shot of dexamethasone. Prochlorperazine. It is available as a 12.5 milligram injection and a 5 milligram mouth dissolving tablet. Both of them are options, but when it comes to an injection, it is 12.5 milligram and most of it goes into the systemic circulation, and therefore repeating it becomes difficult. So when you are prescribing an acute vertigo medicine for the patient to be taken on an SOS basis at home, a tablet is a better choice. The reason is when you give 5 mg tablet, patient vomits or you are not sure whether it has got absorbed, you can always tell the person to take repeat one more without exceeding the allowed dose. This is the advantage of the tablet over this thing. Clonazepam, again clonazepam is again a good drug for acute vertigo. This is another option, especially if you see this patient does not have an option of taking an injectable dexamethasone. Patient has previously had an attack of extrapyramidal side effects with previous Temitil. You want another option. So clonazepam becomes that other option in this patient who doesn't tolerate this thing to break a status migrainosus episode. Also it can sometimes be helpful, especially the status migrainosus where continuous daily mild dizziness is there for days together. Just give clonazepam and then that is broken. Sodium valproate. This again for status migrainosus where the person continues to have vertigo, sometimes even neck pain and headache, goes on and on and on for days together, for a week, the things are not settling, then you can give this. 1000 mg of sodium valproate in 250 ml normal saline over 1 hour. The advantage of giving this approach is, one is it is safe. Second one is, if after half of the dose is gone, the patient is already relieved, you can stop it there and there. But after the full infusion is gone and the patient is still not completely resolved, after 4 hours you can again repeat this thing. Meclizine, again for acute vertigo, especially suitable in pregnancy and breastfeeding. 25 milligram tablet up to 3 times daily can be given if the episode is ongoing. Promethazine is another option, available as a 5 mg per 5 ml syrup, 25 mg injection, 25 mg tablet, especially suitable for children and in breastfeeding, motion sickness prophylaxis in children, acute vertigo in adults and children. About 2 years you can give a dose of 0.5 milligram per kg per dose. Cinnarizine again especially for the acute vertigo after vestibular neuritis or labyrinthitis, even stroke patients. This is a good medicine to control the vertigo. When you need vertigo control for 2 to 3 days together, you can have a 25 and 75 mg tablet. You can give 25 TID for short duration vertigo control after vestibular neuritis. Now what I covered, then mannitol again is an option that is available, especially for a person in whom there is, if you try flunarizine in positional vertigo crisis and that has not been effective, you can always try an injection mannitol also. What I covered so far is all the options that we have for acute vertigo control, that episode control. So many options are there. It is not like we are lost. It is not like we have only one option, 2 options. So many options are there. Depending on what best suits your patient, you can choose the option. Depending on the condition, you can choose the option. Now coming to vestibular migraine, magnesium is the first line drug for vestibular migraine in my experience. It is the first line drug. It is available as a 200 milligram tablet, 1 tablet OD or BD for 1 month, then 1 tablet daily for 1 week every month. Now magnesium has been told as a nutritional support or a nutritional management of migraine. No, magnesium deserves the rank of a proper drug rather than just calling it as a nutritional, because it is pharmacotherapeutically active. It is known, you know that it is used for seizure control, especially in eclampsia. This is the beauty of this magnesium, and to bring about this, it's actually a pharmacotherapeutically active drug. It deserves that. Anecdotally, magnesium has helped even when valproate, it is like valproate is considered the last or something like that, the end drug when it comes to migraine control, because that valproate is an anti-epileptic. When you choose an anti-epileptic to control migraine, you know that where you have stitched. But we have anecdotally seen patients in whom where valproate has not been able to effectively control migraine episodes, magnesium has done the magic. So it really deserves to be actually treated as a proper drug and given the consideration to be given as the first line of medicine because of its safety in these things that you give. The second drug I want to cover for migraine, vestibular migraine, is flunarizine. 5 mg and 10 mg is what is available, can be given in children above 6 years. there are multiple ways in which you can use it. Pulse therapy and abortive therapy are two types that I want to cover here. What is a pulse therapy? If the person has already had an attack that has set in of either of a vertigo because of migraine or headache because of migraine, you give this pulse therapy, that is 1 tablet daily for 5 to 10 days. Abortive therapy is 1 tablet, you tell the patient, you give the prescription to the patient and tell, take 1 tablet, not after the vertigo has set in, not after the headache has set in, but when you get the first indication that you are going to get attack. They feel odd, they have some kind of a sensation, they can predict that the attack is going to come. They feel irritated, they feel the lights are suddenly bright, my mobile phone looks brighter than usual, half the brightness. I usually on other days need to increase it to 75% brightness. Today 25% is looking like 100% brightness. These are different ways in which these people, suddenly they start telling, why is the TV sound so huge, why can't it be this thing? Why? They suddenly start feeling that sound, what is usually the kids are keeping certain sound, now suddenly the sound starts becoming like too loud. That means you are about to get that attack. At that time is the time that you are supposed to take this. So there are multiple ways in which they come to know. Then prophylactic therapy is 1 tablet daily for 1 month, up to 3 months you can give prophylactic therapy. In migraine therapy, there is a approach called battery charging approach, which they coined by Dr. Shushma Sharma. She is a neurologist practicing out of Faridabad. This is a battery charging. What is battery charging approach is, prophylaxis need not be continuous and continued. You give 1 month of prophylaxis, the patient can manage without the need for any other drug for the next 3 months, 6 months, sometimes 1 year, 2 years. Everybody's battery charges, every battery, every phone's battery, depending on the usage and the battery quality, after a charging lasts a certain amount of time. Like that, if you give the drugs for a month, their battery, depending on the individual and the kind of disease or the kind of stressors they are going to, from 3 months, 6 months, 2 years, they can get. Again they get the attack, again recharge the battery with another 1 month of these drugs. This is battery charging approach. Okay. Propranolol is a drug of choice for migraine prophylaxis during lactation. Flunarizine with propranolol, this is 40 milligrams propranolol with 10 milligram flunarizine. Again, this, when one drug is working but not sufficiently enough and other drug is also working but not sufficiently enough, you can use this combination. Topiramate, not to be used in pregnancy or childbearing age because it can be devastating, but otherwise this is a good drug. 25, 50 and 100 mg is available. Start at 25 milligram once daily and do weekly increments till optimal therapeutic outcome is achieved. Who is the person in whom this should be thought of as the first? These are the person who comes with empty cella. These are the people who seem to have who complain of visual obscurations and seem to have a raised intracranial pressure, at least of a sum. There is something, okay, maybe not reaching the diagnostic criteria of IIH, but when you look at the MRI, it looks like there are some signs that there is raised intracranial. These are people who, when you stoop down and suddenly get up, they have some postural symptoms. These are the people who have change in the intracranial pressure. So these people you can consider topiramate as one of the first choices. Amitriptyline, explain to patient when you are giving amitriptyline that we are giving anti-migraine dose and not antidepressant dose, because the moment you give amitriptyline, after half an hour of interview, after a lot of examination, then you make a diagnosis of vestibular migraine and then give the patient amitriptyline. Patient goes home, talks to the Google brother, sister, aunt, uncle, whoever it is, and then they find out that it is an antidepressant, and they will tell that you doctor, you looked sympathetic, you looked knowledgeable, you seem to have diagnosed me correctly at that time, but finally you told that I am mad, okay, by giving the prescription. So now the person needs to be told in the beginning itself, I have given a drug, if you Google it, it will come as antidepressant, but there is a difference. The way you are counseling to the patient is, this hand is hand, the same hand, if I lightly touch, it is a pat, it is like shabash, you are doing well, but if I do this, it is a slap. So the dose makes a difference in the indication. That is how they will understand. Otherwise they would not know how the same drug, this fellow is telling it is antidepressant, and how it is convinced. But if you give an example, they are convinced like this. Okay. Duloxetine is again, this is an antidepressant itself, but again this also works in migraine with when the other things are not working, this is also an option. Cyproheptadine, especially in children, is a good choice, especially if you are having a patient with benign paroxysmal vertigo of childhood. If you remember the case discussions that we did in the morning, I had an eminent, beautiful panel today, expert panelists who gave real insights. And this was one of the drugs that was mentioned there when it is required for children for benign paroxysmal vertigo of childhood, not to be confused with positional vertigo. BP is not benign paroxysmal, paroxysmal vertigo of childhood. It is not positional vertigo. It sounds like that. In children, they get, this is a beautiful drug. Now, migraine. So we covered two things so far. We finished acute attack of migraine, then we completed, we acute attack of vertigo, different options, then vestibular migraine. What are the options we covered? Now migraine, you know it is migraine. Symptoms come back immediately on stopping the prophylaxis. Then what to do? Then vitamin B12 deficiency is a high likelihood possibility, 1000 mcg on alternate days for 5 injections. You correct the underlying nutritional deficiency. That could be the trigger for the migraines, and then that migraines also will come under control. Meniere's disease, what are the options? This is a disease whose diagnosis is super straightforward and easy. There is no ENT surgeon who cannot make a diagnosis of Meniere's disease without any investigation. Whatever patient tells the story and you know the diagnosis. Diagnosis is easy. Treatment is the most bothersome in this, because some things work, some things don't work. But what are the things that I have found to be beneficial in a lot of patients? Spironolactone, 25 mg tablet. Give it in the morning daily. Spironolactone. Orally once a day. This works. Okay. Then the other one that works is beta-histine. Beta-histine. There is a certain group of people in whom spironolactone works. There are a certain groups of people in whom beta-histine works. If your patient belongs to one of these groups, your patient is lucky, you are lucky on that day. Because only on that day, because another day you will get another patient for whom both of them don't work. Because if they work, they are the best. Okay. Now beta-histine. We need to know something about beta-histine. Every time people are telling, okay, this is histamine, that we need to understand a little bit. This is histamine in the brain is secreted from a location called tuberomammillary nucleus. Beta-histine is a H3 antagonist, that is a presynaptic antagonist. What is this? Presynaptic antagonist means for every neurotransmitter, these of modulatory neurotransmitters that are stimulated, there is always a feedback mechanism as to how much can be secreted into the synapse. The feedback mechanism decides whether it is that further secretion should stop or further secretion should continue. Whether further secretion should stop or further secretion should continue. Beta-histine stops that feedback loop and therefore continues to ensure that there is further and further histamine that is secreted. Therefore we see, even with such high doses of beta-histine whatever, because it doesn't have that much of a H1 agonist effect on the periphery, you really don't know. Though there is a theoretical possibility of a acid peptic disease, though there is a theoretical possibility of a asthma, we really don't see that much in the patient population. We see a rare patient with acid peptic disease, rare patient with asthma in spite of this, because rather than being a prohistamine, this works more like enhancing the brain to produce its own histamine rather than being the supplier of histamine. Okay, this is the thing. Now what is this? How much to give? 16 mg TID for 1 month. Okay, is a good reasonable thing for Meniere's attacks to abort them and bring them under control. The other thing about this we need to know is this is the fifth aminergic system that is not taught in the medical college. In the medical college we are taught about dopamine, norepinephrine, serotonin, acetylcholine. We know dopamine reduction, acetylcholine reduction, these are all associated with Parkinson's disorders. You know norepinephrine reduction, serotonin reduction, these are all associated with diseases called that are like depression, these kind of things. We all know about that. These are all the things, these are neuromodulators which have which are secreted in one particular location, like a substantia nigra, locus coeruleus, some place, but have effect on the overall functioning of the brain. Similar, only 4 of them have been taught to us in the medical college. What was missed out in the medical college is the central histaminergic system, which starts in the tuberomammillary nucleus and has widespread action along the brain. Now, why I am mentioning this here is, in elderly people we are seeing central histamine deficiency related loss of energy. By afternoon 2 o'clock they feel all loss of energy, they are no longer energetic, and you start giving 1 tablet of beta histine in that particular person and the person is active. Lot of people tell that I am active, lot of people tell that I am active after taking 1 tablet 8 mg 16 mg and I am active for the next 4-5 hours. So if you see that not as a suppressant, stimulant, suppressant, all these are literature that are told by companies. If you just come out of that and see it as it is, then if you see it as the 5th aminergic system, it will get the same respect as the other ones, and then you will start using them. You will start seeing options in the elderly people where it can be beneficial. Coming back to Meniere's disease, pyracetam also can help in some people. Okay, 800 milligram twice daily for 1 year you have to give this pyracetam. Okay, this again is a beautiful drug in some patients. Okay, in whom nothing else is working. This is worth a trial. If there is benefit, you continue for 1 year. If there is no benefit, 1 month attacks are continuing, then stop it immediately. Metoprolol is again one more thing that works for Meniere's disease. Okay, metoprolol is an antihypertensive agent. Metoprolol is also a beautiful agent. Counterintuitively, because we think beta blockers means make the person get a syncope, but counterintuitively metoprolol is known to benefit in syncope also. But here metoprolol also as an anti-migraine agent also. Maybe there is a subgroup of patients of Meniere's disease whose Meniere's is actually caused by migraine, and maybe because of that we are seeing this kind of results where metoprolol is also helpful in Meniere's patients. Vestibular neuritis is the next condition I want to cover. Deflazacort 30 mg BD for 5 days and then stop. There is no need to taper, no need to do anything. If you really want to give more, maybe you can give for 10 days. No need for any tapering. Deflazacort 30 mg BD. Any steroid, short duration, no tapering required, and that is going to sometimes lead to the reduction in the inflammation, return of the function. Even prednisolone is a choice. Okay, 60 mg OD in the morning for 5 days and then stop. Vestibular paroxysmia, what is the drug? Carbimazepine. Okay, start with 100 mg OD. Escalate, you can escalate up to 500 mg as a total daily dose. You can give it divided, okay, whatever, and then only declare it as ineffective. Don't give 100 mg, 200 mg and then tell this vestibular paroxysmia. These are short spins that the patient gets, recurrent attacks of short spin, few seconds to few minutes that the patient is getting again and again. But be very careful that this can cause Stevens-Johnson syndrome in people, and when you are giving carbamazepine, you have to keep monitoring the blood counts. Smallest change in the blood count, you have to stop. Single ulcer in the mouth, if the patient tells, you have to tell them, you have to call me back immediately. If there is a single ulcer in the mouth, you have to immediately tell, stop the drug, don't take it. This patient has to be educated, and with responsibly you have to give the carbamazepine. Motion sickness, this is where the real revolution has happened. Motion sickness, anybody tells, the thing that comes to your mind is, what is the thing that comes to your mind? The thing that should come to your mind from now onwards, forget about avomine, whatever, hyoscine, whatever, flunarizine, that is it. If there is only one message from here, I want all of you to carry back home, the drug of choice for motion sickness is flunarizine. 5 mg tablet 30 minutes to 1 hour before travel. You take and see the patients thanking you again and again. The reason is, though they know the other drugs are effective, they don't take it because they take 1 day, 1 tablet, and 3 days there is dry mouth. There is blurring of vision. There is so many other problems with that routine motion sickness drugs. Whereas if you give flunarizine, motion sickness is controlled and the other side effects are not there. I have also treated a patient with motorist disorientation syndrome with flunarizine very effectively. Short spontaneous spins, very short, brief attacks of spontaneous spin, just one jerk. He's a teacher, he's taking class, suddenly he gets one attack. These kind of things are there. This Nilothpal taught me Divalproex sodium, 250 milligram OD for 3 to 6 months, and the patient will be good. Metoprolol again works here for short spontaneous spins also, because some of the mechanisms could be migraines. Divalproex and metoprolol both work for migraines. Any balance complaint in an alcoholic person, if there is a history, the problem with alcohol is, if you talk to the patient, do you take alcohol? Patient tells no. Next question is, when did you stop? He tells last week. He has been taking all his life, but then because he stopped it last week, he tells no as the answer. Okay. So you have to ask them, but we have to be clear about our question. Okay, how long did you take, or when did you stop? This is the important thing. If the person has been an alcoholic for a few years, then any balance complaint in them, forget about what diagnosis, all those things, diagnosis, everything else will come to later. First give them thiamine. See the magic happening. Give tablet magnesium 200 mg BD for 1 week, then call the next week for thiamine therapy, because thiamine can induce a magnesium deficiency when it is already present, and that can have some other problems. So therefore first preload with magnesium for a week, then give thiamine. 100 mg per ml injection is what you get. 500 mg in 500 ml normal saline intravenous infusion over 2 to 3 hours is my thing. I give this one injection, then I can repeat it after a week, then I can repeat it one more week later, whatever. Sometimes patient themselves come on an SOS basis. Doctor, last time you gave me, next 6 months I am taking alcohol without any problem. Now I am having problems, please repeat that. And then I give that and send them. This is like spoiling them. Orthostatic hypotension, this is one of the commonly missed diagnoses. The reason is because of a lack of understanding that orthostatic hypotension is a relative diagnosis, not an absolute diagnosis. Patient, when they come to the clinic, need not be hypotensive. Their blood pressure relatively falls compared to their supine blood pressure. So if the supine blood pressure is 160 by 110, if the sitting or standing blood pressure comes to 140 by 100 also, still it is orthostatic hypotension. This is one important reason. Second important reason for this is very commonly missed diagnosis. Another commonly missed diagnosis in the OPD is walking difficulty because of excellent BP control. Excellent BP control in a person all his life who has been hypertensive is also going to cause a relative insufficiency of blood supply in the brain, and they will not. So you will need to come down on the control. So, but that is next. Orthostatic hypotension. So fludrocortisone, when nothing else works, fludrocortisone can help in these people. But there are other measures. This is the pharmacotherapeutic measure. There are non-pharmacotherapeutic measures like strengthening the abdominal muscles, strengthening the calf muscles, taking adequate water, and stopping the ill-advised advice of giving salt restriction. There is a problem with us, that is, any person comes and tells dizziness, little vertigo, and you have little time, first advice you tell is reduce the salt. No, that can be counterproductive, especially in the elderly. Okay. Bothersome interictal tinnitus in a vertiginous patient. Some drugs you need, some solutions you need for these people. Some of them which have worked in my practice. Gabapentin for some reason. Okay, 100 mg twice daily, but there is no guarantees. Like the other drugs where there, I was so confident here. The moment I am telling this, I little go low the moment it is tinnitus. But you can try this. In a small subgroup of patients, it does become less bothersome. Orthostatic tremor, again gabapentin. Orthostatic tremor is when the person, after standing in the same time for some times, they start feeling like they are becoming shaky, weak. Then when you palpate the foot, this is not a visualized tremor, this is a palpated tremor. When you palpate the calf muscle or the tibialis anterior muscles, then you will see the vibration. Then you can give gabapentin for them. Other drugs that need some special mention, acetazolamide. It can be useful in intractable BPPV. It can be useful in mini ARS. It can be useful in some migraines, episodic attacks, yes, idiopathic intracranial hypertension. All of these things. Some BPPVs don't respond to repositioning maneuvers. You give acetazolamide for 5 days and see the magic happening. Or even when the thing is coming again and again. Cinnarizine with dimenhydrinate is a beautiful thing, especially for some patients with otolytic dysfunction. and especially for also in some people after repositioning they are having a lot of symptoms, it can control those symptoms. Aspirin again can be a good drug in recurrent vertigo, especially when the MRI shows that there is a vertebrobasilar dolichoectasia. Pyridoxine again in female patients, this is a very good thing with vestibular migraine. This is a good add-on drug. Coenzyme Q10 has been anecdotally in few patients with Meniere's disease, it in itself has been able to help stop the vertigo attacks. And one of my patients, after starting, I tried everything else, nothing worked, and then coenzyme Q10, and then he's been symptom free for the last 5 years, but he continues to take coenzyme Q10. Melatonin 1.5 to 3 milligram 1 hour before intent. If the person is not having a good sleep, and then because of that, one of the contributors to his recurrent vertigos or daily split second split thing, making him sleep, her sleep or him sleep better is a very good. So melatonin is one of those drugs you should be thinking of. Okay, it should have a very low threshold to give melatonin to these people and try to see if the symptoms worsen, symptoms become better. And I have found good results with melatonin as a drug. The next drug, melatonin, is the person not being able to fall asleep. But post-COVID, we are seeing a lot of people who come and tell, I'm always sleepy, I have no energy, always sleepy, always not able to concentrate in the meeting. What they are telling, what I am telling, no. And always I am feeling like I am always dizzy. This group, solriamfetol, is the new drug that has come. We have SSRIs, that is selective serotonin reuptake inhibitors. We have selective norepinephrine reuptake inhibitors. All these reuptake inhibitors we have. Now we have, for a change, dopamine reuptake inhibitor. Dopamine, norepinephrine and dopamine reuptake inhibitors, especially in people who feel drowsy all day, post-COVID, okay, post-severe viral infection, these kind of things, drowsy and dizzy all the time, and especially also people with narcolepsy and cataplexy on these things. Any person with circadian rhythm sleep related disorders also, this solriamfetol at a 75 mg dose, either once or twice, again is a drug that we can think of. With that I complete. And then last one, amino acid supplementation. In recurrent BPPVs, amino acid supplementation is a beautiful combination that you should be thinking. People spoke about, talked about, researched about vitamin D deficiency, giving vitamin, giving calcium, giving so many other things. But if you ask me today if there is one drug that has really in my hands been effective in stopping the recurrences of BPPV in people who are prone for recurrences, it is amino acid supplementation. The logic here is the otolith matrix protein needs some amino acids there to complete it. The matrix protein is the one that holds in the matrix the calcium carbonate crystals. If the matrix protein is deficient, the calcium carbonate can become loose and cause BPPV, because the calcium carbonate from the utricle has to become loose, go into the semicircular canal to cause BPPV. If you don't allow it to become loose by strengthening the matrix protein, then the chances of recurrences become less, and this is amino acid supplementation. Thank you all. Thank you so much for the being such a beautiful audience, and thank you organizers for giving me this opportunity to give this oration. Thank you all. Thank you again.
Thank you, Dr. Srinivas. It was a very interesting and illuminating pharmacotherapy of the different conditions. I think all of us got pointers how to treat the various conditions.
Thank you, sir.
Thank you, ma'am. Felicitation corner.
Yes.
Yeah. Thank you all. Thank you so much, and apologies for coming between you and the dinner. Thank you.
Yes. So we have our central committee, Nebaoicon, will first felicitate, and there will be one felicitation from organizing committee. I request both the outgoing president and president to do the honor. Sorry. Yeah. Now I request our Joint Secretary, Dr. Sabita Neuk, and Scientific Chair, Rinku Rahman, to do the honor from Organizing Committee. No, it's okay. Surojit will hold it. Now I request ETVR sir to felicitate our chairperson. Sir. Sir. Yeah, I'll take. Sir. Sir, they are my teachers. I have Thank you, everyone. Though our scientific session is over, but we will continue our session. We have a wonderful cultural night today. We need maybe 10-15 minutes to prepare the sound. We are using different sound. You can have a cup of coffee and come, but we'll be starting within 15 minutes.